Wait.
Hello. Welcome back, everyone. Okay, so today we are going to do our boot camps. That will be the complete review of our cardiology, which we have completed yesterday. Okay, so we're going to start our lecture with the cardiac embryology. Then we will do anatomy, physiology, pathology. Okay, so please, everyone, keep yourself mute, and whenever I ask a question, then you can answer. Okay. All right, so that's my humble request to everyone. Please keep yourself mute, and there should be no disturbance because if you actually, talk in the middle or you are unmute, that's going to break my rhythm and it will be the loss for you guys. Okay. All right, so going to start our class now. Okay, so cardiac embryology. So first we discuss the cardiac embryology. That's called the cardiac looping. Cardiac looping means the heart tube. Okay, cardiac looping. So heart tube, the heart tube when it grows, it's on the right side of the chest. So during embryology, the heart tube is on the right side of the chest. Heart tube, heart tube. Suppose this is my, okay, so suppose this is my right side. Who's using this whiteboard? Please try to don't use whiteboard. If you cannot zoom in your screen, stop, don't do this like this. If you try to zoom in with your iPads or touch screen, with the mobile phone, it's going to happen. Okay. So please do not do this. Otherwise, it will create a problem for me. Okay. So heart tube is actually, grows on the right side of the chest. Okay. So because it's a mobile phone, when you try to zoom in, you will use the whiteboard. Okay. So that's actually your heart tube being there. Okay. So this is suppose my right side. This is my right side. My left side. So heart tube grows like this. It's on the right side. So this is right side. Okay. So this is the side where the heart tube is actually growing. Now, if you look at the adult heart is on the left side. Is it? So heart tube has to rotate. It have to rotate to the left side. So during embryologic development, it has to rotate to the left side. So it will rotate to the left side and it will come to the left side like this. Okay, so this will be your adult heart, which will be looking. After that, I will discuss the derivative of heart tubes with you guys. So this will be called your heart tube. Okay, it's now on the left side. So can anybody tell me what's the name of the structure which will facilitate the movement of the heart tube from right side to the left side? Yep,
Dining.
very good.
Dining.
Cilia,
Dynam.
let's say cilia. Very good, cilia. Now, cilia is actually the motile tissue in our body, and cilia has some arms. Ciliary arm that is called Dynan arm. So Dynan arm is going to facilitate
tí UK máa ṣe
Dynan
UK
arm.
máa ṣe ni pé a kọ́ set exam fún ná.
Okay, so Dynan arm is going to facilitate this movement. Now, there's a one disorder in which this Dynan arm is actually defective that is called Cartan-Jenner syndrome. So Cartan-Jenner syndrome is actually defined. What is the cause of Cartan-Jenner? It's due to the defective Dynan arm of the cilia. So it is going to affect the rotation of heart tube from the right side to the left side. As a result, the heart tube will remain where it will remain on your right side. That's called dextrocardia. Okay. So dextrocardia, that will be the cardiac manifestation of Cartan-Jenner syndrome. So can anybody tell me what's the respiratory manifestation of your Gardner syndrome?
Bronchiectasis.
Yes, very good. Bronchiectasis and your sinopulmonary infection, because normally cilia plays a role in the clearance of the necrotic debris or waste products out of the sinuses or out of the respiratory tract. So if you have the defect here, you're unable to clear it. Okay, that will be your respiratory manifestation. Now we also do have what? We also have the manifestation of the gut, GI system manifestation. So what will be my GI system manifestation of the your Carter-Jenner syndrome? Yep.
Cystic fibrosis.
Situs inversus. Situs
Inversus. Very good. Situs inversus means your liver is going to be on the left side and the spleen is going to be on the right side. So opposite location of the viscera of the gut is called situs inversus. Very good. Now other is called reproductive manifestation, where we will get the infertility. Infertility because of the immobile sperms. Sperms are going to be immobile, and in the females you are going to get the ectopic pregnancy because of the immotility of the fallopian tubes. Okay, so that will be all about your Carter-Jenner syndrome. Now we are going to discuss the heart tube and its derivatives. Okay, so heart tubes and the derivatives. So in order to understand the derivatives of the heart tube, first you have to focus on my picture and the blood flow, how the blood is actually flowing through the heart. So suppose this is my heart tube. I'm drawing this bigger structure. This is called heart tube. So this heart tube is going to give rise to the every structure of the heart. You know, within the heart we have the four chambers. These four chambers will be derived from this heart tube. So we will actually now see how these four chambers are derived from these heart tubes. Okay. So this bigger structure is called heart tube. Now heart tube is actually divided into your five structures. It's actually divided into five structures. So in order to understand these derivatives, first you have to understand the blood flow. So my blood flow is going from downward to upward direction. Look at this. So this is how the blood is actually flowing through the heart tube. So this is the direction of blood flow. So in order to understand the derivative, you have to first understand the blood flow. So blood is actually flowing from the downward direction to the upward direction. So downward is actually, this is a point. Inferior point is the entry of the blood. This is a point where the blood enters the heart. Enters the heart. Okay. And this is a point where the blood leaves the heart. This is the exit point. So upward point is actually exit point, and downward point is the entry point. Okay. So the first structure of the heart tube is called your sinus venosus. It is called what? It's called sinus venosus. So this is called your sinus venosus. The structure which is very near to the entry point is called sinus venosus. Okay. So sinus venosus is very close to the entry point. Can anybody tell me what is the name of the heart chamber which receive the blood from the periphery, which receive the blood from the peripheral veins? Yep.
Coronary sinus.
No. I mean,
Atrium.
Vena cava.
right atrium. It's actually right
Right atrium.
right atrium. IVC is actually draining into right atrium. So this, can I say this sinus venosus, which is the first part of the heart tube, it will give rise to the right atrium. Sinus venosus will give rise to the right atrium. Okay, right atrium. Because right atrium is the first point to receive the blood. Okay, so this sinus venosus is further divided into two types. It's divided into two areas, right horn and the left horn. So it's being divided in the middle by the right horn. The right horn will obviously give rise to the right atrium. Will obviously give rise to the right atrium. Now, right atrium have the two parts. It has a smooth part and the rough part. So the area which is very close, to the entry point, it should be smooth or rough. You know, your entry point should be always smooth. You know, your entry point should be smooth. So can I say like this? Right horn of the sinus venosus give rise to smooth part of the right atrium. Okay. Now left horn. This is my left horn, which is going to give rise to what? Left horn is going to give rise to your one structure which drains into the right atrium. Can anybody tell me what is the name of the vein which
Coronary sinus.
Pulmonary veins.
No, that's called coronary sinus. Very good. is a venous drainage of the heart. Venous drainage of the heart is called coronary sinuses. So coronary sinus is actually derived from the left horn of the sinus venosus, which is going to drain into your right atrium. Okay. So that is actually the sinus venosus, which is the first part of the heart tube. Now coming to other part of the heart tube. So after right atrium, the blood will go where? Blood is going to go to the ventricles. Is it? Blood is going to go into the ventricles. Okay. So what will be my second part of the heart tube? The second part of the heart. So you see, after this sinus venosus, the blood is actually going still to the atrias. Is it? So second part of the heart tube is called what? It's called primitive atrias. No. So first I have to complete the atrias. Is it? I didn't have. There should be right atrium. Smooth part is actually there, but there should be rough part as well. And I should also have the smooth part of left atrium as well. So the second part is called atria. If you focus at the blood flow, second part will be the atria. Because after right atrium, this is smooth part of the right atrium. After smooth part, the blood should go into the rough part of the right atrium as well. So primitive atrias are going to give rise to what? They are going to give rise to your smooth part. So smooth part was coming from the sinus venosus. So it will give rise to the rough part of the right atrium. Rough part of right atrium. Rough part, which is muscular part. Is it? Rough part of right atrium and rough part of the left atrium. Rough part of the left atrium. So atrias will give rise to what? They are going to give rise to your left atrium and the right atrium. Okay, so that will be the rough part. Okay, smooth part of the right atrium was coming from where? It was coming from the sinus venosus. Now you guys must be thinking from where the smooth part of the left atrium is coming. You're driving the smooth part. You're driving the rough part of the left atrium from atrias. So which structure will form the smooth part of the left atrium? Anyone?
Pulmonary vein.
Pulmonary vein.
Why?
Because it is exit point.
It's entry point, not exit point. Okay.
Sorry,
Entry point. No, don't be sorry. Don't be sorry. You're trying. That's a good thing. I really appreciate that. So because I already told you the entry point should be always smooth. Entry and the exit point should be smooth. So this was all about atrias, and now from atrias the blood will go where? It will go to the ventricles. Okay. So the third part will be called what? Third part of the heart tube is called your ventricles. They are called primitive ventricles. Now these primitive ventricles are going to give rise to what? Muscular part of the right and the left ventricle. So that will be the rough part of the right and the left ventricle will be coming from the ventricles. Okay. Now from ventricles, the blood will go where? That will be the fourth part. So here I'm actually forming the rough part. Okay. Ventricles will give rise to the rough part. Rough part. Okay. Now from rough part of the ventricles, the blood will go to the smooth part of the left ventricle. And smooth part should be very near to what? It should be very near to the outflow tract. So the area of the heart tube which give rise to the smooth part of the right ventricle, it is called bulbous cordus. This will be called bulbous cordus. So the fourth part of the heart tube is called bulbous cordus. Bulbous cordus. Okay. So bulbous cordus is actually very near to the outflow tract. So this is going to contribute to the smooth regions of the right and the left ventricles. Okay. That's actually called all right. So smooth part of the right and the left ventricle comes from the bulbous cordus. Now the last part or last region of the heart tube is called what? It's called truncus arteriosus. So truncus arteriosus is going to give rise to your aorta and the pulmonary trunk, because after ventricles, the blood will go where? It will go to your aorta and the pulmonary trunk. So these are the regions of the heart tube. They are very simple to understand and very easy if you just consider the blood flow. So look at this. Blood flow is going from downward to upward direction. So we will start with the right atrium and we will end with the aorta. Okay. But you guys must be thinking, if you look at the adult heart, you don't see right atrium sitting on the bottom. you see the right atrium is sitting on the upper portion. It's sitting on the superior area. So what will happen? Your heart tube is going to rotate. It's going to rotate in the inferior superior direction. So it will flip, it's going to flip in the opposite way. Okay. So it's going to flip in the inferior superior direction. So when it flips in the inferior superior direction, you're going to get what? Your right atrium will come on the top and your aorta is going to come on the bottom. Ventricles will come in the bottom. Okay. So that is called the heart tube derivatives. And that's a review of the heart tube. We already discussed that in our classes. Okay. All right. So that is all about the heart tube. Now we're going to discuss our septation of the chambers. So now we are going to divide the chambers. So we discussed the derivatives from where the chambers are coming. Now there's a point that there's a time to discuss the septation. Now we are going to divide atria and the ventricles into their respective chambers. Okay. Okay, so now we discuss the septation of the atria and the ventricles. Septation. So first, we discuss the septation of atria. So in order to start that, first I would love to discuss nomenclature. So remember, septum means what? Septum means the bridge. The term septum means bridge. Septum means bridge. Okay. And other term is called ostium. Term ostium means what? Cavity. It means cavity. It means cavity. So septum and the ostium. Ostium means cavity, and other term is called your primum. Primum means the structure which forms first. The early or initial structure. Simply initial structure. And other is called your primum. Then we have the secundum. Secundum means the second structure which forms. Okay, secundum. Okay, so we have the septum, ostium, primum, secundum. These are the nomenclature which we are going to discuss. Now, after last term which we will discuss is called foramen. Foramen means the small opening, not a bigger opening, but small opening. Small opening. Okay, so now we're going to discuss the septation of the atria. How does we divide the atria? So initially you look at this, your atrias are looking like this. They are the single cavity. They're the single cavity that needs to be divided. They needs to be divided. They are the single cavity that needs to be divided. Okay, so what is the name of the cavity which is actually present in between them? This will be called ostium primum. So suppose this is my right atrium and this is my left atrium. Okay. Now right atrium, the left atrium, they are actually communicating with each other. They are actually communicating with each other by the cavity. And what's the name of this cavity? It's called your ostium primum because it's the first cavity. I already told you first cavity will be what? Ostium. Ostium means cavity, primum means the first. So the structure, the bridge which will grow to close this ostium primum, it will be called what? Septum primum. So septum primum is actually coming downward. Septum primum is actually coming downward towards the endocardial cushion to actually close your ostium primum. Okay. So this will be your septum primum. So the first bridge which is formed will be called septum primum. Okay. And this forms why this is forming to close your ostium primum. Now, when it completely closes the ostium primum, the communication between right atrium, the left atrium is completely closed. But during the fetal development, we want communication between right and the left atrium. So there will be necrosis within your septum primum. So you get what? Necrosis within septum primum. And when you get necrosis within septum primum, you will actually produce one structure within septum primum. Okay, so this will be the structure which is actually formed here. So when you do the necrosis, so necrosis of your septum primum is going to produce one channel, one cavity that will be called ostium. That will be called ostium ostium secundum. That will be called your ostium secundum. Okay, that will be called ostium secundum. Okay, ostium primum was actually what? Ostium primum was the initial cavity which is being closed by the septum primum. So ostium secundum is actually formed due to the necrosis of the septum primum. Now another bridge will grow on the sides. Another bridge will grow on the sides. Another bridge is going to grow on the sides, which is going to close the ostium secundum. So what will be the name of this bridge, red one? Can anybody tell me?
Septum secundum.
Septum secundum.
Septum secundum. Septum secundum will completely close the ostium secundum, but very small area will not be closed. That small area is actually here, it will not be closed. And that small area will be called what? It will be called foramen ovale. Foramen ovale. So foramen ovale is a small opening which is being left in your ostium secundum, which is not being closed by your septum secundum. So it will actually maintain the shunt between the right and the left atrium because it is required for the fetal circulation, and I will discuss why. Okay, so this smaller opening is called foramen ovale. Now this foramen ovale needs to be closed as well, but it will not close during the fetal life. It will close after the birth of the baby. So when the baby is born, this structure will be closed, and this foramen ovale will be closed when your pressure in the left atrium increases. So when you increase the pressure in the left atrium, what will happen? You will get what? Septum primum will be fused against the septum secundum. So when your septum primum fuses with the septum secundum, they will close the foramen ovale, and the foramen ovale will be converted into what structure? Can anybody tell me what's the name of this? So when you close the foramen ovale, it will be converted into fossa ovalis, which will be, if you look at the gross picture of the heart, you will see some central depression within the interatrial septum that will be called your fossa ovalis, and that will completely form your interatrial septum, which will completely close the communication between right atrium and the left atrium. Now failure of the septum primum to fuse with the septum secundum will lead to the disease that will be called your padded foramen ovale, PFO. Okay, so PFO is going to be due to the failure of the septum secundum to fuse with the septum primum. Now, can anybody tell me how will the PFO present, padded foramen ovale? How it is
Usually asymptomatic.
Asymptomatic.
very
Mostly asymptomatic, but sometimes paradoxical.
Yeah,
Very
emboli.
Very good. So it will be asymptomatic. It will be asymptomatic, but if it present during the adult life, it will present with a paradoxical emboli. Can anybody tell me what is paradoxical emboli?
The venous thrombus clots bypass the lungs and they enter into the systemic circulation.
Yeah, paradoxical in the term paradoxical means opposite in the medicine. It means the
Yes.
opposite. Okay. So normally what happens when your venous thrombus, when you get DVTs, deep venous thrombosis, it should always lead to pulmonary embolism. It should not enter into the systemic circulation. But because of the padded foramina or the PFO being open, the DVT or deep venous thrombosis will get a chance to enter into the systemic circulation, and that will lead to the stroke in the patient. So what is a normal pathway of the DVT? So you get DVT, that DVT will go through the IVC, okay, and from IVC it will go to the right atrium, is it? And from right atrium, where it will go? It will go to the right ventricle, is it? And from right ventricle, it should go to the lungs, is it? And from lungs, it will never go forward. It will stop in the lungs. It cannot pass through the pulmonary vein because pulmonary vein is very simple. So you get what? Pulmonary embolism. It ended up having pulmonary embolism. Okay. So what happened in the PFO? In the PFO, the DVT will go first to the IVC in the same manner. DVT goes to the IVC. Okay. When it goes to the IVC, it will from IVC it will go to the right atrium, and from right atrium it will go where? It will go to your directly. It will go to the left atrium. Through PFO, it will go to the left atrium. Very good. And from left atrium, it will go to the left ventricle. And from left ventricle, it will go to the aorta. And from aorta, it will go to the carotids. Carotids, okay. And from carotids, it will go where? It will go to your brain or middle cerebral artery. And you get the stroke. Okay. So that will be the sequence of the events which are happening within your, okay. Okay. This is actually your sequence of the events happening. All right. In case of your PFO. All right. So that's all about your PFO, pedal foramen ovale, and that's all about your interatrial septum. Now, if your interatrial septum does not form at all, if you get the defect in the septum primum or septum secundum, if that doesn't form at all, you will get what? Atrial septal defect. That's called AST. And can anybody tell me what is the most common form of the atrial septal defect?
Secondum.
Secondum. Very good. So secondum will be there. Now, what is the cause of ostium secondum type of the AST? What's the cause of that? Which septum does not form? Septum primum or septum secundum? So ostium secundum AST is due to what? Ostium secundum AST due to what? Ostium secundum doesn't form because your septum secundum doesn't form because septum secundum is actually close by your, okay. So ostium secundum is actually close by your septum secundum. All right. So that's actually all about AST. And can anybody tell me what's the cause of AST?
Down syndrome.
Exactly. Very good. It's being seen in the Down syndrome. Very good. So that was all about your interatrial septum developments. Now we're going to discuss your, okay, ventricular septum development, how the ventricular septum actually form. That is actually ventricular septum. Ventricular. I see a lot of the new faces today, and I'm sorry if I'm actually quick enough here. I'm trying to be very slow and explain everything for the new students, but we have already covered these things. These are just a brief review we are doing here. Okay, so ventricular septum is actually there. Anybody here is facing any problem or everything good? All good?
Yes.
Everything good?
Yes. Yes.
Yeah.
I'm asking from the new students because I see a lot of the new faces here. Okay, so just stay here. We will be actually going long today. Okay, all right, thank you.
The only thing I didn't get was ASD occurs if the premium if septum premium fails to fuse with septum secundum. Am I correct?
If the septum primum, okay, that's what did you? So you
I
did
said atrial septal defect occurs if
atrial septal defect are caused if your septum primum or septum secundum doesn't form at all. So the most common type of atrial septal defect is called ostium secundum defect. And I told you ostium secundum defect will be due to failure of the formation of the septum secundum. If your septum secundum doesn't form, the ostium secundum will be open cavity. So that will allow the blood to go from right atrium to the left atrium or from the left atrium to right atrium, depending upon the pressure. Get it?
Yes.
Okay.
Yes, thank you.
Very good, no problem. Okay, so ventricular septum. So ventricular septum will be formed that will actually divide the right ventricle from the left ventricle. Okay, so there are two components of the ventricular septum. So I'm going to first draw the cavity here. So this will be my cavity, single cavity, and this single cavity is there. Okay, very good. Endocardial cushions, excellent. So these will be the endocardial cushions. They will be called the block. Endocardial cushions are the blocks of the mesoderm. The red color structures are called endocardial cushions. Now these endocardial cushions are there. So ventricular septum have the two components. One is called membranous component and it's called muscular components. So muscular component is actually formed from the ventricles itself. So this will be your black color will be my muscular component, which is derived from the base of the, I would say, the base of the ventricles. So this is actually called, sorry. Okay. So this is actually called the muscular septum. So muscular septum is actually composed of what? It's coming from the muscles of the left ventricles. That is why it is called muscular septum. Okay. Muscular septum. So muscular septum will fuse with the membranous septum, and blue color will be my membranous septum, which is coming from upward. And this will fuse like this. When they both fuse together, they will form a ventricular septum. So this will be my membranous septum. Okay. So as I told you, muscular septum is coming from the ventricular wall itself. From where the membranous septum is coming? Can anybody tell me what is the derivative of membranous septum? What's
Neural crystals.
very good, Archana? What did you say?
Neural crystals.
Excellent. Neural crest cells. And what structure of neural crest cell is contributing to the membranous septum? That will be your aortocopulmonary septum, APS septum. Do you know aortocopulmonary septum, which separates your aorta from the pulmonary trunk? They also contributes to the formation of ventricular septum as well. So membranous septum is actually derivative of aortocopulmonary septum, which in turn is a derivative of neural crest cells. Okay, so when they fuse together, they will form your ventricular septum. Now, failure of this fusion or failure of the formation of the membranous or muscular septum will lead to ventricular septal defect. Now, what is the most common cause of the ventricular septal defect? Membranous septum or muscular septum? Which one doesn't form most commonly?
Membranous.
Very good.
Membranous.
Membranous defect is very common.
Membranous septum.
Very good. Membranous will not form. So when membranous doesn't form, what will happen? The blood will flow from the left ventricle to the right ventricle. Okay. Left ventricle to the right ventricle. So that will be the membranous septum. Now, what is the cause of this? Can anybody tell me in what disease I get the membranous ventricular septum defect?
Down syndrome.
Down.
Tetralogy of Fallot.
Very good. Tetralogy of Fallot is there. Excellent. Down syndrome was there. Very good. Tetralogy of Fallot is there. Very good. What else? Yep. Fetal alcohol syndrome. Fetal alcohol syndrome is going to not a truncus. You can say it is associated with the truncus arteriosus. Why it is associated with the truncus arteriosus? Because in truncus arteriosus, aortocopulmonary septum does not form. So the disorders of aortocopulmonary septum are always associated with the membranous VSD. Okay, so that was all about your VSD. It's very simple. Now we divide the chambers. Now it's a time to divide your outflow tract. It's a time to divide the outflow tract. So now we are going to divide the outflow tract. So suppose this is my, okay. So this will be my outflow tract. Okay. So this is my outflow tract. And you guys know that outflow tract is derived from your truncus arteriosus, is it? And outflow tract is divided into aorta and the pulmonary trunk. Okay. So it is actually divided into aorta and the pulmonary trunk. Okay. So this will be your, all right. So this will be my aorta. Okay. And this will be a pulmonary trunk. So aorta and the pulmonary trunk are divided from each other by one septum that is called your aortocopulmonary septum, which is in the midline. And it's normally spiral shaped like this. This is spiral shaped. This is spiral shaped. And this is actually forming. This is called aortocopulmonary septum. Now, aortocopulmonary septum is a derivative of your neural crest cells. Neural crest cells. Okay. Now, aortocopulmonary septum will extend downward, will actually contribute to the membranous VSD. I already told you it will contribute to the membranous ventricular septum. Okay. So this is actually your APS, which is actually neural crest cells. Okay. Now, if your aortocopulmonary, now we are going to discuss if this structure does not form. If this structure does not form, then what disease we are going to get. Okay. So failure of the aortocopulmonary septum to form. If your aortocopulmonary septum is completely absent, what's the name of the pathology? Yep.
Truncus arteriosus.
Very good. Truncus arteriosus means single trunk will be going outside of the ventricles. Very good. That will be truncus arteriosus. So truncus arteriosus means the aorticopulmonary septum does not form at all. That's due to your defect in the neural crest cells. Neural crest cells are not functioning properly, so you are going to get what truncus arteriosus. Okay, so truncus arteriosus is actually going to be there. Now, other pathologies there. You see, normally aorticopulmonary septum is a spiral structure. So, if your aorticopulmonary septum is not spiral, it is actually your linear structure. So, if it forms linearly like this, so when the aorticopulmonary septum forms linearly, what's the name of the disorder in which aorticopulmonary septum is linear? That will be called transposition of great vessels.
Transposition of the great vessels.
Excellent, very good. In this, what is going to happen in transposition of great vessels? Aorta will come from the right side and the pulmonary trunk will come from the left ventricle. So they are in the opposite direction. They are in the opposite direction being there. Okay, that will be called transposition of great vessel. Can anybody tell me what maternal disorder will lead to transposition of great vessels in the babies?
Gestational diabetes.
Diabetes.
Why? What's the reason? Diabetes. What's the reason?
Glucose is very toxic for
Glucose is
neural
toxic to the neural crest cells.
Excellent, very good. Glucose is toxic, so it will affect the neural crest cell function. That will be called transposition of great vessels. Now, what happens if your aorticopulmonary septum is deviated more towards the pulmonary trunk? Instead of being in the middle, it's more deviated to the pulmonary trunk like this. Like this. So it actually do what? Leads to reduce lumen of the pulmonary trunk. The pulmonary trunk become 20% and your aorta become 80% more larger. So in what disorder the aorticopulmonary septum is displaced more towards the pulmonary trunk? What's the name?
Pulmonary stenosis.
Tetralogy of Fallot. So why it is called tetralogy of Fallot? Because we are actually getting 4 symptoms in these patients. There are 4 consequences. Who did this? Who removed my picture? Okay. All right. I'm going to try it again. Please do not zoom in your screen. If you are unable to see it, I mean it's a fault on your side, not our side. Okay. Okay. So what is tetralogy of Fallot? So tetralogy of Fallot was simply the deviation of your aorticopulmonary septum more towards the pulmonary trunk. So this will be like your aorticopulmonary septum going more towards the pulmonary trunk. Okay. Okay. So this will be your pulmonary trunk and this will be your aorta. This will be your aorta. Okay. So pulmonary trunk is actually becoming 20% of the lumen and aorta is actually 80%. I don't know who's doing this. I have to actually, okay, it's fine. Let me shift the control from everyone. Okay, perfect. Now you guys cannot do this. Okay. Okay, no problem at all. Okay. So what is going to happen, as I told you, the APS septum is deviated more towards your
Pulmonary trunk.
pulmonary trunk. Okay. Pulmonary trunk. So pulmonary trunk is actually, so this is called tetralogy of Fallot. So in the tetralogy of Fallot, you see four consequences are there. So if you just remember what is happening, you see pulmonary stenosis is happening. So if you remember pulmonary stenosis, everything is a consequence of pulmonary stenosis. So when you get pulmonary stenosis, that's the first finding. And because of pulmonary stenosis, you will get what? Right ventricular hypertrophy. Is it? And right ventricular hypertrophy is there. It means the pressure in the right ventricle is very high. So in the tetralogy of Fallot, you also get VSD. Why do you get VSD? Because you will get membranous VSD because the defect of aorticopulmonary septum. So you're going to get what? Membranous VSD, which will allow the shunt to go from right ventricle to left ventricle depending upon the pressure within the chamber. Now, fourth thing in the tetralogy of Fallot, you are going to get overriding of the aorta. And that overriding of aorta means aorta is going above the pulmonary trunk because of bigger structure. It's a bigger structure, so it will go above the pulmonary trunk. All right, so these will be the tautology of fellow, and these are the disorders of your I would say the outflow tract. Now, after outflow tracts are being developed, now after outflow tract we have the valve development. Valve development. So in the heart, we have 4 valves being there. 2 valves are actually present. 2 valves are actually present between the atria and the ventricles, and 2 valves are present within the outflow tract. So the valves which are present between atria and the ventricles, that will be called mitral and the tricuspid valve. Can anybody tell me what is the embryologic derivative of them? From where they are coming, mitral and the tricuspid?
Endocardial cushion of the AV canals.
Very good, very good. Good job. More precise, very good. Endocardial cushion of the AV canals are there. Very good. And what is the derivative? What is the derivative of aortic and the pulmonary valve? Aortic and the pulmonary valve.
Endocardial
Cushion of the outflow tract.
Very good. Endocardial cushion of the outflow tract. So what are the valvular pathologies which we are going to get here? Valvular pathologies.
Either stenosis or regurgitation.
Yeah, you might get the, very good. So you might get the atresia. Atresia means the valve does not canalize. Failure of the valve to canalize is called your atresia, okay? Or it could be your stenotic. Stenotic means the valve is very difficult to open. It's very narrow being there. It's difficult to open being there. Or you might get the displacement of the valve. When the valve actually displaced from its normal location, it will lead to the pathology that's called abstinence anomaly, okay? Abstinence anomaly.
Maybe the bicuspid aortic valve.
Sorry, your voice is so slow. I don't know what you want to say.
Bicuspid aortic valve.
I cannot hear you, sorry. Okay, so abstinence anomaly is actually what? You know, what is the cause of abstinence anomaly? Anyone?
Lithium.
Lithium. Mother using lithium during pregnancy will be the cause here. Very good. Okay. So that will be your abstinence anomaly. All right. So, now that was all about valves. Now we're going to discuss, okay, so aortic arch derivatives. So aortic arches are going to give rise to the arteries. So we have the 6 aortic arches. 6 aortic arches are being there. Out of them, 5 actually contributes to the arteries development. So aortic arches. So aortic arch number 1. So you have to start aortic arch from your maxillary region, from your cheek area. So first aortic arch is going to give rise to the maxillary artery. Very good. Very good. First aortic arch is going to give rise to the maxillary artery. Very good. Yep. First aortic arch give rise to the maxillary artery. Very good. What is the second aortic arch? I'm not writing because somebody is actually trying to remove my words. So let's discuss. Okay. I'm just looking at my host tools to actually put a privacy here. Very good. So can anybody voluntarily teach us the aortic arches? Yep. Derivatives. Yeah. Very good. So second and the third, but who wants to tell?
Common carotid and the internal carotid.
Okay. Let me change the policy because somebody is actually trying to remove my words again and again. Yeah, I'm trying to remove those ones. I'm trying to remove them. Okay. All right, so first arch is actually going to give rise to maxillary arteries, and the second arch is going to give rise to stapedial arteries, and the third arch, little bit going down, it will going to give rise to your common carotid arteries and the proximal internal carotid artery, and the fourth arch is actually going to be aortic arch, and your it's going to give rise to your aortic arches and the subclavian arteries. All right, so that will be your, and the sixth arch is very simple, it gives rise to the pulmonary arteries being there. All right, so that was all about your, and we don't have a fifth arch actually regresses. Now we're going to discuss the fetal circulations. Fetal circulation. So in order to understand the fetal circulation, first you have to start from the placenta. First we have to start from placenta. So it's a role of the placenta to send the oxygenated blood to the brain. So how placenta is going to send it to the brain of the baby, that we are going to see now. Okay, so placenta, we start from the placenta. So from placenta, the one vessel actually carry the oxygenated blood to the heart of the baby. So placenta is a site of oxygenation. So the vessel which carry the blood to the heart of the baby, or which will drain the blood into the IVC, that will be called umbilical vein. Umbilical vein, it's a responsibility of umbilical vein to send the oxygenated blood to the heart of the baby. Okay, so the oxygen saturation in the umbilical vein is actually around, okay, so it's almost, I would say SaO2 is actually equals to 80. It equals to 80. Okay, it's equals to 80. Now, umbilical vein is a branch of the portal vein. It's a branch of the portal vein. So in order to drain, in order to bypass the portal circulation, there should be some shunt being available. So what shunt is available, which will send the blood directly to the IVC and will bypass the portal circulation and will drain the blood into the IVC directly. That will be called your, what's the name of that? That's called ductus.
Ductus venosus.
Ductus venosus, excellent. Not a arteriosus, venosus. So ductus venosus will actually bypass the umbilical vein blood directly into the IVC. Okay, so IVC has a deoxygenated blood being there. So when you mix the oxygenated blood with the deoxygenated blood, the SaO2 is going to be little bit go down. It will become 70%. Okay, it will drop, and from IVC the blood will go where? It will go to the right atrium. Now from right atrium, where will the blood go? Where will the blood will go? Blood will go to the right ventricle or left atrium?
Left
Right,
atrium.
Well,
Left atrium.
very good, left atrium. And what's the name of the shunt which was open? You see? Yes. That will be called what? That will be called your
Foramen ovale.
very good, foramen ovale. So that is the reason here we kept the foramen ovale open, is it? During fetal circulation. And you see, so 70% blood, 70% saturated blood reaches to your left atrium. From left atrium, the blood will go to the left ventricle. And from left ventricle, it is going to go where? It's going to the aorta. And from aorta, where it will go? From aorta, it is obviously going to your brain. Okay, it will go to the arch of aorta, which will actually supply the blood to the brain and the upper extremities. But there's another shunt being present. Suppose this will be my arch of aorta. This is arch of aorta.
Ductus arteriosus.
Arch of aorta. And after giving the blood to your right, I will say brachiocephalic trunk. This is my brachiocephalic trunk. This is my left common carotid. This is my left subclavian artery, and this one is my okay. This one is actually your pulmonary trunk. This is your pulmonary trunk being there. Okay, so there's a one shunt being present between the pulmonary trunk and the arch of aorta. That will be called your ductus arteriosus. So ductus arteriosus will allow what? Ductus arteriosus will allow the blood of the pulmonary trunk to enter into the arch of aorta. Okay, why it will allow it during the fetal circulation? Because during fetal circulation, your lungs are collapsed. So you have to send the deoxygenated blood back to the placenta, because placenta is a site of the oxygenation. So here I get what deoxygenated blood is actually there, where my SaO2 is how much? SaO2 is equals to 40%, and here the SaO2 was actually equals to 70%. Okay, so when your 70% blood mixes with the 40% saturated blood, the saturation will drop to 50%. Is it 50%? So it means during the fetal life, your lower extremities are going to receive the deoxygenated blood, and the upper extremities receive what? Oxygenated blood. Now this 50% deoxygenated blood will go down and supply your descending aorta, and from descending aorta, the one branch will come. What's the name of that branch which is going to send blood to the placenta back? That will be one artery. And what's the name of that artery? Can anybody tell me the name of this artery which is supplying the blood to the...
Iliac artery?
No, no. This is suppose my placenta being there. This is my placenta. Very good. Asif, very good, Asif.
Umbilical.
That will be called umbilical artery. Very good. Okay. Placental. Okay. Placental artery is actually there. So this is your placenta. So umbilical artery is going to supply the deoxygenated blood to the placenta. Now placenta will again make it oxygenated, and the blood will go again through the umbilical vein to the IV. So the cycle is going to be repeated. Cycle is going to be repeated. All right. So this is how the fetal circulation is actually taking place. So it has to bypass the 3 shunts. Okay. 3 shunts are actually there. All right. Okay, now you see these shunts need to be closed. If they don't close, they will maintain these right to left shunting during the adult life. So after the birth, when the baby takes its first breath, it will lead to the closure of the ductus arteriosus. The ductus arteriosus will be closed and will be converted into the ligamentum arteriosus. Ligamentum arteriosus. So can anybody tell me what are the factors which will facilitate the closure of ductus arteriosus?
Prostaglandin E2.
Yes, what did you say?
Prostaglandin E2.
So that will be oxygen. Very good. One will be oxygen. When the baby takes its first breath, the oxygen level in the lungs increases. So that will lead to the closure of the ductus arteriosus. Very good. So one will be your, all right. So one will be your oxygen. Very good. What are the other aspects?
Prostaglandins.
And said prostaglandin should be decreased. So that will be when you separate the placenta, placental separation. Placenta is separated, so it means prostaglandin will go down. That will lead to decreased prostaglandin. So you will get the closure. Okay. So that will be
Decreased pulmonary resistance.
exactly. Okay. So that will be there. Now, if your ductus arteriosus does not close, the disease is called PDA. Padded ductus arteriosus. So in order to close this PDA, we will actually give what? What are the causes of PDA? First, anybody tell me the causes of PDA. What are the causes of PDA?
Prematurity and congenital rubella syndrome.
Very good. Prematurity, because premature babies will not have the properly formed lungs. They do have the ARDS, so they don't have oxygen being there. Okay. Prematurity and the rubella syndrome. Very good. So how you're going to close it? How you're going to close? What is the treatment?
Indomethacin.
Indomethacin, very good. What else?
Inhibitor of prostaglandin.
Yes, what else?
Oxygen.
Oxygen, excellent. Good job, very good. Oxygen is very important to close this one. All right. So there are certain diseases in which you want to keep the ductus arteriosus open. There are some diseases I will discuss that total anomalous pulmonary venous return, tricuspid atrasias. So in these diseases, we have to keep the ductus arteriosus open to maintain the shunt between the aorta and the pulmonary trunk. So can anybody tell me how I will keep the ductus arteriosus open? What I will give to the baby?
Prostaglandins.
Prostaglandin what? Prostaglandin E1, E2, EF what?
E1.
Excellent. You want to give the prostaglandin E1 and
E1 and E2.
Exactly. Very good. All right. So that was all about your fetal circulation. Now I already discussed the derivatives, fetal derivatives seen in the adult. So ductus arteriosus is converted to ligamentum arteriosus. Ductus venosus will be converted to ligamentum venosus. Okay. And what about the foramen ovale? Foramen ovale will be converted to fossa ovalis being there. Okay, an umbilical vein is going to form what? Can anybody tell me what is the umbilical vein is going to form in the adult life?
Ligamentum
arteriosus.
Ligamentum venosum.
That
Ligamentum teres, round ligament.
round ligament.
Maybe,
Excellent. That will form the ligamentum teres hepatis, which is the round ligament of the liver. Very good. And what's the derivative of umbilical artery?
Medial umbilical ligament.
Very good. Medial umbilical ligaments is going to be there. Okay. So in this way, we complete the embryology. Now we're going to shift into the anatomy. So before starting the anatomy, we are going to take a 2 minutes break. Okay. So I will be here within 1 minute or 1.5 minutes. Okay.
yeah. Right, but listen.
All right, so I'm back. Okay, so we're going to discuss the cardiac anatomy. So heart anatomy is there. So if you look at the heart anatomy, we have to look at the anterior, what chamber is making the anterior surface, and what chamber is making the posterior surface, and what is making your medial surface and the lateral surface. So anterior surface of the heart. So there's a one chamber. If you look at the heart, the anterior surface will be very close to the anterior surface of the chest wall. Is it? Anterior surface. So what chamber is actually making the anterior surface? It will be your right ventricle. Right ventricle is very close to the anterior chest wall. It's very close to the anterior chest wall. So right ventricle is going to make the anterior surface of the heart. And why it is very important to know, because any kind of the blunt chest trauma, any kind of the penetrating chest trauma, it's going to first affect your right ventricle. So chest trauma is going to affect your, okay. Now opposite, if you look at the cardiac MRI or cardiac CT scan, opposite to your right ventricle, there will be the one chamber which will form the posterior surface of the heart. Posterior surface of the heart, that's very on the posterior surface. It means this surface is going to be very close to your vertebral bones. This will be very close to the vertebral bone, and that is going to be the left atrium. Is it? So left atrium is very close to your vertebral bones, because vertebral bones are seen on the posterior side. So left atrium is very close. So why it is very important? Because very important structures are in close relationship with the left atrium. Left atrium is very close to your trachea. Is very close to the trachea, because trachea is running posterior to the left atrium. Another structure which is very close to the left atrium will be your esophagus. Okay, esophagus. And the third structure which is very close to the left atrium will be your left recurrent laryngeal nerve.
Recurrent laryngeal.
Recurrent laryngeal nerve. Now, there's a one disease which will lead to the enlargement of left atrium. So once your left atrium get enlarged, it will compress these structures. It can compress your trachea, it can compress your esophagus and the left leg. So the disease is called mitral stenosis. Mitral stenosis, you will get what? You will get, if you compress the trachea, you will get what? You will get dyspnea, shortness. Okay, if you compress the esophagus, what will you get? You will get dysphagia. And similarly, if you compress your left recurrent laryngeal nerve, you will get hoarseness. Hoarseness. Okay, so you're going to get the hoarseness. The syndrome is called your Ortner syndrome. Okay, syndrome will be called your Ortner syndrome. So, all right, so coming to the medial surface. So, what border forms the medial surface, or what chamber form the medial surface of the heart? Anyone who knows the answer?
Right atrium.
Right atrium.
Very good, excellent, excellent. So it's not an important one. I just want to complete the anatomy here. So right atrium is actually there. And what about the lateral border?
Left ventricle.
Left ventricle. Very good. And coming to the inferior surface. So inferior surface of the heart is formed by what structure?
Right and left ventricles.
Very good. So 2/3 by the left ventricle, and a 1/3 is 1/3 by your right ventricle. Okay. So can anybody tell me what's the other name of the inferior surface of the heart?
Diaphragmatic.
Diaphragmatic, because it's very close to the diaphragm. So that will be your inferior surface being there. Okay, so that's about your heart anatomy. Now we discuss the pericardium. So pericardium is the outer covering of the heart, is called pericardium, which is simply the supportive layers of the heart. So pericardium is composed of the three layers from outside to inside. One is called fibrous pericardium, then called parietal. Then we have the visceral pericardium, which is also called epicardium. Okay. This is also called epicardium, which actually visceral is actually there. Now, between the visceral pericardium and the parietal pericardium, there's a one space that's called pericardial space, which is composed, which contains one fluid, which contain the fluid. And what's the role of that fluid?
Decrease the friction.
Decrease the friction. Very good. It acts as a lubricant. It acts as a lubricant being there. Okay. So that's the one role of the pericardium. Another role of the pericardium serve as an attachment point for the blood vessels. So blood vessels enters the heart through the pericardium. Okay. So pericardium is there. Now, pericardium is actually innervated by what nerve? It's being innervated by pharynx nerve. So what pericardial layer is innervated by pharynx nerve? Visceral or parietal?
Parietal.
Excellent, very good. Visceral is actually more autonomic because it's inside. So parietal is actually there. So when you get pericarditis, it leads to the irritation of the pharynx nerve. And once you get the irritation of pharynx nerve, you're going to get the referred pain because pharynx nerve also supplies to the other regions of the body. So can anybody tell me where will the pain refer?
Neck
Shoulder,
and
left
arms.
shoulder.
Left shoulder.
Excellent. It's going to be going mostly left shoulder. Excellent. Very good. Good, precise. Left shoulder. Very good. It's going to go to the left shoulder. Okay. So it's going more towards the left shoulder. Very good. Or it can go to the both shoulders. So shoulders can be there, neck could be there, and the arms could be there. Okay. So that's
Yeah.
what about the pericardium being there. Now we discuss the coronary blood supply. So coronary blood supply means you should the left ventricular blood supply should be on your tube. Coronary blood supply. Coronary blood supply. Okay. So we have what? We have the coronary artery comes. This is suppose my coronary artery being there. And this coronary artery, when it comes on the pericardial surfaces, it's going to divide into two arteries. Main two arteries, it's going to divide into left coronary artery. So this will be my left coronary artery. This will be my left coronary artery. And this will be my right coronary artery. So it divides into two arteries, RCA and the LCA. This is my LCA, LCA. This is my RCA. So RCA, right coronary artery. So left coronary artery will take the responsibility of the left side of the heart. It will supply the blood to left side. Left side. And right coronary artery will obviously supply the right side of the heart. Plus, it is also going to supply the left side as well. So right coronary artery is going to supply the both regions. So first we will discuss the branches of left coronary artery, then we will discuss the right coronary artery. So left coronary artery will, who's doing this? I don't know who's this guy. I don't know who's this. I have to agree, okay. So after this, nobody can do this. I'm going to, and nobody can talk in the middle now. I'm going to be very strict now because if I don't do this, you keep wasting my time. Who has the control? I don't know. I actually changed the policy. Still, how you can do this? Who's doing this? Who's Mosmi actor? How she get the control? Yeah, it says now, Bell. I don't know how they are getting the control. I don't know why.
So there is a tab on top where you can control. And so maybe that's why their screen is showing. So if there's a way to stop that, then they will not be able to control at all.
No, how to control that? Could you please guide me? I'm actually trying to find it. I went to the host tools and
It's showing on our screen with all the names and the editors. And if you touch the screen by mistake, then you get the control. And so that's why these people are getting control.
how to actually change the policy? Could you please guide me? Do you know how to?
Dr. Muhammad, there is like a little bar where you can see people. At the end, there are two toggles. One is collaborator cursors and the other is meeting participants can edit. You need to turn both of them off.
So one is in the host tools. I have to go to the host tools.
I don't know what this is called, but on the side of the whiteboard, there are these whiteboard tools, like the ones you use for presentation. It says laser, it says comment panel, and there is a little tab which has all the people, like 68 people who are watching
Yeah.
you.
Yeah.
So when you click that, at the end, there's two toggles. One is collaborator cursor, and at the end, it's meeting participants can edit.
Yeah, I
You
get
need
it.
to turn both of
Thank you. I
yeah.
have to turn
Yes, sir.
these both off.
Yes, sir.
Thank you so much. I appreciate it. Okay. Thank you. Now they cannot do it. Okay. Hopefully no. Okay. Thank you so much. Okay.
If someone does, then remove the chat.
Yeah, I mean, to be honest with you, Rahul, it keep actually debating my focus. And you guys have realized that, is it? Okay. So I don't
No, it's when people join in from their phone, if they touch their screen, it automatically gives
yeah,
them
it's
control.
not their yeah, it's not their
Yeah.
fault. Because when they try to zoom in the screen, and it's being by mistake, I know. But now they cannot do it. Thank you. Okay. All right. Okay. Okay, so now we're going to do, so can you guys see my screen properly now? Everything good? Okay, so let's discuss the coronary blood supply. So we were actually discussing a coronary blood supply. So suppose this was my coronary artery cams. So this is my coronary artery. Okay, so this was my coronary artery. Now this coronary artery is going to divide into the two main arteries. One will be called left coronary artery. Okay, and other is going to be your right coronary artery. So this is my left coronary artery. Now left coronary artery is going to take the responsibility of the left side of the heart, and the right coronary artery is going to take the responsibility of right side, obviously, but left side as well. Okay, so right coronary artery is actually there. Okay, so first we will discuss the left coronary artery, then we are going to discuss the right coronary arteries. So left coronary artery is running on the surface of the left ventricle. It will run on the surface of left ventricle. So it's going to run like this. So it is divided into two branches. So anteriorly, it will go and descend anteriorly on the surface of left ventricle like this. This will be called your anterior descending artery, and this will be called left anterior descending artery, LAD. LAD is actually running on the anterior surface of the left ventricle. So other branch will be called your left circumflex artery, which will make a U-turn, from the anterior surface, and it will run on lateral surface. So suppose this was my blue structure is called left ventricle. This is my left ventricle being there. So blue structure is called left ventricle. This is my left ventricle. So the artery which is running anteriorly on the left ventricle will be called left anterior descending artery, and the artery which is running on the lateral surface, it will be called your left circumflex artery. This is your left circumflex artery. Okay. This will be called LCX. So first we will discuss the areas of left ventricle supplied by your LAD. Then we will discuss the area supplied by left circumflex artery. Okay. So LAD, left anterior descending artery, is also called the artery of anterior surface. Anterior surface.
Yeah, what does it make yam? Yeah, I had it this night. I didn't even think to stress. I'm never making That's when I was hungry. Like I was smelling it.
Okay. So LAD is also called what? It's called the artery of the anterior surface. Anterior surface. So it is running anteriorly. So whatever structures are present on the anterior surface of the left ventricle, that will be supplied by your LAD. So one structure, it's called anterior surface. Anterior surface. Can anybody tell me what are the other structures which are present on the anterior surface of the?
So anterior 2/3 of the IV septum.
Very good. 2/3 of the interventricular septum. Very good. Anterior 2/3 of, and your papillary muscles. Very good. That will be called anterior lateral papillary muscle or posterior lateral papillary muscles.
Anterolateral.
So left anterior, the name is called left anterior. So it will supply all the structure which are present on the anterior surface of left ventricle. So other will be called your anterolateral papillary muscles. Anterolateral papillary. So anterior areas of the anterior surface of left ventricle is actually supplied by your LAD, and left anterior descending artery. Okay. Now I would love to discuss here the posterior surface because it's completely opposite of the anterior surface. So what artery is going to supply to the posterior surface of the left ventricle? So artery which supplies, so we covered the anterior surface. Anterior surface means LAD. Posterior surface is supplied by posterior descending artery, PDA, which is completely opposite to your left anterior descending artery in the location. So it is running on the posterior surface. So it is going to supply to your posterior surface of left ventricle. Very good. And what other structures are present on the posterior surface? Yes, I'm going to discuss from where it is coming. Yes. So it supply your posterior surface of left ventricle. Yep.
Posterior medial papillary muscle.
Posterior medial papillary muscles. Excellent. Posterior medial.
Posterior 1/3 of IVS.
Posterior medial papillary muscles. Very good. And other will be posterior 1/3 of the interventricular septum. So look at this. These areas are completely opposite to the areas of the LAD. Okay. So you guys must be thinking PDA is a branch of what artery? So 90% of the time, PDA comes from the right coronary artery. So depending on the PDA being coming from right or left, our circulation in the heart is divided into right dominant and the left dominant. If your PDA comes from the right coronary artery, the circulation is called what? It is called your right dominant circulation. It will be called right dominant. Okay. Right dominant. Okay. Now what is going to happen if your PDA is actually coming from the left coronary artery, which is 5% of the time. 5% of the time, it actually come from your 5% of the time, it actually come from your left circumflex artery. So it will be called what? It will be called left dominant circulation. It will be called left dominant circulation, and rest of the 5% it coming from the both. If PDA comes from the both right coronary artery and the left circumflex artery, what's the name of the circulation? Yep.
Codominance.
Codominant.
Codominance.
Codominant. So that's all about your PDA being there, which is completely opposite. So we supplied. So look at this. We supplied anterior surface of the left ventricle, posterior surface of left ventricle. Now it's a time to supply the lateral surface of left ventricle. Lateral surface. So what artery supply the lateral surface of left ventricle? Anyone?
LCX.
Left circumflex. Very good. Left circumflex is actually there, which is going to supply to the lateral surface of left ventricle. Now, remaining surfaces are what? Remaining surface is called inferior surface. So what artery supply the inferior surface of left ventricle?
Right coronary artery.
Excellent, excellent, very good. Right, RCA is going to supply to your inferior surface of the left ventricle. Okay, so this is the one supply of the RCA, and right coronary artery also give rise to the posterior descending artery. Okay, so these are the supply of the left ventricle. Easy, it should be on your trip. Anterior divided into the anterior surface, posterior surface, lateral surface, and the inferior surface. Okay, all right. So these are the supply being there. Now coming to the areas supplied by the right coronary artery. So as you guys know that right coronary artery is running on the right side of the heart. So whatever structures are present on the right side of the heart, they will be supplied by right coronary artery. As I see SA node is there. Very good. It supply SA node, and it supply your AV node. AV node. and it also supplied to your right atrium being there. It's going to supply your right atrium is being there. Okay, so right atrium is actually there. Now it's supplied to your right ventricle as well. Can anybody tell me what's the name of the branch of right coronary artery which supplied to your right ventricle?
Right marginal.
Right marginal artery.
Very good. That will be acute marginal artery being there, or obtuse marginal arteries are there. Why they are called margins? Because they are running at the tips. They are running at the tips. So that's why they are called the marginal arteries being there, or obtuse marginal being there. Obtuse marginals are the branches of the left circumflex which go downward. Okay. So if you get right coronary artery blockage, you are going to get the nodal dysfunction. So nodal dysfunction means you will get what? Decreased heart rate will be there. Okay, bradycardia there, hypotension is going to be there. Okay, bradycardia, hypotension or heart blocks will be there because you will get the ischemia of your AV node. Heart blocks will be there. Get it? So these will be your can anybody tell me what is the name of the vein which drains the heart? We discussed
Coronary sinus.
coronary sinus. Very good, coronary sinus. And what is the other importance of coronary sinus? Other importance of coronary sinus is that it's the only vein of the body which carry deoxygenated blood in the body. Deoxygenated blood in the body is seen in the coronary sinus only. Okay. Now, the coronary blood supply is, at what? During what time in the cardiac cycle we see the peak coronary blood supply? During systole or diastole?
Diastole.
During diastole. Very good. So it will be true for it. So during diastole, there will be peak left ventricular blood flow. Peak left ventricular blood flow. What about right ventricular blood flow? Is right ventricular blood flow also peak during only diastole or during both phases?
During both phases.
Why?
Both phases.
Why? Very good. You're right. Why? Right ventricular blood flow can be peaked during systole and during diastole both. Why? Plus systole. Why?
Because the right ventricle.
Because heart do softly.
To equalize the pressure.
Because right ventricular contractions are not that much powerful, or they are not that much strong. So they will not collapse the coronary artery. Okay, right ventricular contraction doesn't generate much pressure as compared to the left ventricles. So it will not lead to collapse of the coronary artery. So no collapse of the coronary artery will happen. Okay, that is a difference. That is a difference between the blood flow between left ventricle and the right ventricle. Okay, so that was all about your blood supply, blood flow. And I don't know what was your question. Somebody was asking me a question about does AV node depend on the coronary dependence, or it's on the. So AV node is actually from the right coronary artery. It's only from the right coronary artery. I know there was some confusions in the group on that day, but better is to keep the things very simple. Just think like this: AV node is actually supplied by right coronary artery. Okay. So now we're going to jump into the cardiac physiology. So before going into cardiac physiology, we will discuss the cardiac output and its variables. So cardiac output is actually defined as what? The amount of blood which is ejected by left ventricle with each cardiac cycle is called cardiac output. Now cardiac output is equals to what? It is equals to heart rate
into
times stroke volume.
Stroke volume.
So if you increase any parameter, the cardiac output is going to be increased. So first, like we will discuss the stroke volume, then we will discuss the heart rate. So let's discuss the stroke volume. Can anybody define the stroke volume for me?
Volume of blood ejected by the left ventricle during each cycle.
Very good. Volume of blood ejected by left ventricle with each cycle is called the stroke volume being there. And this could be the forward blood flow or backward blood flow. We don't care. Okay. So any amount of blood which is actually going outside of the left ventricle is called stroke volume. So what are the factors which are going to increase the stroke volume? Increase the stroke volume. So one will be, it will be increased preload. When you increase the preload, it is going to increase your stroke volume according to the Frank-Starling. What does the Frank-Starling say? If you increase the preload, it's going to increase your stroke volume. Okay. So increase preload, increase stroke volume will be there. Very good. So what physiology during pregnancy or exercise? Very good. Pregnancy or exercise? Or exercise. Okay. And when you decrease the afterload, so what physiology will decrease the afterload? Again, it will be exercise. When you're exercising, it's going to decrease it. Okay. And when you have the increased contractility as well, contractility is increased, so you're going to have the increased cardiac output. Okay. So that will be your stroke volume being increased. Now we will discuss what are the parameters which will increase the contractility, increase the preload, and the afterload being there. Okay. So first we will discuss the contractility. So what are the factors which will increase the contractility? Anyone? Yep.
Exercise.
Yep. Sympathetics will be there. Very good. When you get increased beta 1 stimulation. Beta 1 stimulation. Increased beta 1 stimulation. Very good. Calcium. Very good. When you increase the intracellular calcium. Increase calcium. Very good. What else?
Anxiety.
Digoxin.
And diazy. Very good. Digoxin. Very good. Yes. Anxiety, digoxin being there. Okay. Or when you increase the cyclic AMP inside the cell. Okay, that will lead to the phosphorylation of myosin proteins, and you are going to get these one. Okay, so these are the factors which increase the contractility. Now, factors which decrease the contractility, that will decrease your heart rate, or sorry, decrease your cardiac output. Okay,
Beta blocker.
Beta blockers.
beta blocker, very
Okay.
good. It means you decrease cyclic AMP. Very good.
Calcium channel blockers.
Heart failure, excellent.
Heart failure.
Heart failure, very good. What else?
Acidosis.
Acidosis, excellent, very good, because it will actually decrease the contraction of the muscles. Very good. And other is called calcium channel blockers, that will be varimpable and the deltaism being there. Okay. Now preload. Preload is going to be there. So can anybody tell me how I will increase the preload to the heart? What
fluids?
maneuver, what exercise? Because when I do venoconstruction, more blood will go to my heart. Exercise.
What?
Exercise will increase the venous return to the heart. How? Because
What in? What?
okay. So what will be the other parameters? What will be the how I'm going to reduce the preload? Reduce the preload will
Hemorrhage.
Yes, what did you said? Standing could be there.
Hemorrhage.
Hemorrhage, standing can be there, not anemia. Anemia doesn't decrease the preload. Okay. Okay. Hypovolemia, you can say hypovolemia, which and nitroglycerin, obviously. Nitroglycerin can be there. Okay. So these are going to reduce your preload. Okay. Now afterload. Afterload is actually the resistance against which the left ventricle is actually contracting, or the pressure in the aorta is called your afterload. So afterload is
Aortic stenosis.
okay. Aortic afterload is also known as the mean arterial blood pressure. Okay. So afterload is going to be increased. So what are the diseases which will increase the afterload in the aorta?
Aortic
Aortic
stenosis.
stenosis.
Aortic stenosis.
Yeah, aortic stenosis, you can say hypertension, chronic hypertension, or aortic stenosis. They are going to increase the afterload. So if you increase the afterload, your cardiac output will decrease. Is it? Cardiac output is going to be decreased. Okay. So, and how I can decrease the afterload? I do the arteriodilators. Arteriodilators are there. They are going to decrease it. Okay. That will be your hydralazine, nitropuracide. These drugs are going to decrease it. Okay. Now, coronary oxygen demand. Coronary oxygen demand. So, what are the parameters on which the cardiac oxygen demand depends? Cardiac oxygen demand is increased by what parameters? Okay. So one parameter will be when you increase the contractility. Second, when you increase the afterload, obviously it's going to increase your oxygen demand. And heart rate, if you increase the heart rate, or when you have what? Increased wall tension. When you increase the tension of the left ventricular wall, okay? So that will actually determines the cardiac oxygen demand being there. And there's a one disease in which we will love to discuss the myocardial oxygen demand. Can anybody tell me the name?
Angina.
Angina, very good. So you will decrease the myocardial oxygen demand by decreasing the contractility, decreasing the afterload, and decreasing the preload. Okay, so can anybody tell me two drugs which treats the angina that we use in the combination?
Beta blocker and nitrate.
Beta blocker.
Beta blocker,
Nitrates.
nitrate. Nitrates will decrease the preload, beta blocker will decrease the contractility. Okay, so that's all about parameters being there, and they're very simple one. Now we're going to discuss your equations for the stroke volume, ejection fraction, and the mean arterial blood pressure. Okay, so stroke volume is also equals to whatever you give to the heart and whatever it is removed by the heart. So end diastolic volume minus end systolic volume. That will be called stroke volume. Suppose if your end diastolic volume is 120 and end systolic volume is 20. So it means 100 ml is your stroke volume, okay, which is amount of blood going outside, okay. So if you increase end diastolic volume, your stroke volume will increase. If you decrease end systolic volume, your stroke volume will increase, okay. So this is how we actually calculate the stroke volume. Now ejection fraction. Ejection fraction is ratio, which is actually the measure of the contractility of the left ventricle. So how much is the contractility of left ventricle being present? We will actually measure with the ejection fraction. Okay, so ejection fraction is actually calculated by your stroke volume divided by end diastolic volume. End diastolic volume, okay. So stroke volume can also be equals to your end diastolic minus end systolic divided by end diastolic volume. So it's a ratio, okay. So what is can anybody tell me what's normal ejection fraction for the heart?
55 to 60. 50 to 70%.
55% to 60% or 70%. That will be 65. So depending on the ejection fraction value, our heart failure is classified into two types. If your ejection fraction is between 45 to 55%, it will be called what? It will be called mild heart failure. Mild. If it is between your 35 to 45, it will be called your moderate heart failure. And if it's less than 35, it will be called what? It will be called severe heart failure being there. Okay. So that is it, all about your stroke volume. Oh, sorry, ejection fraction and stroke volume being there. Now cardiac output, I told you the equation of cardiac output being there. Now cardiac output can also be calculated by fixed principle. Fixed principle. Fixed principle being there. So what is actually fixed principle being there? Fixed principle actually takes oxygen consumptions into the accountability for calculating the cardiac output. So fixed principle will be equals to rate of oxygen consumption, rate of O2 consumption, okay, divided by arterial O2 contain minus venous O2 contain. Okay, so that will be a fixed principle. So according to the fix, if your body is consuming a lot of the oxygen, it means there will be more cardiac output. Is it? More cardiac output. And if you have the more arterial O2 versus venous difference is more, it means your cardiac output is going to be what? If it is more. If the difference between arterial O2 and the venous O2 concentration is more, what will be my cardiac output?
Low.
Very good. It's going to be low. Why? Can anybody tell me why?
Denominator?
Denominator being there, and what's actually the anticipation of that? Suppose my
So more
arterial O2
oxygen is being
arterial O2 content is 60 and the venous O2 content is 30. Here I get the denominator 30 number. 30 is there. Okay. Similarly, if my arterial O2 content is at least 90 and the venous O2 content is at least 10, what will be it will be 80. So my cardiac output is going to be low. Now,
Yeah.
can anybody tell me why? Because why cardiac output is going to be
Oxygen consumption.
because oxygen concentration is already high in the arterial blood. Arterial blood already have the more oxygen. So if there's a more oxygen in the arterial blood, there's no need to increase the cardiac output, is it? But
Yeah.
if the arterial O2 content decreases, then your body will try to increase the cardiac output, is it? So
Yeah, compensate.
what happened to compensate? Excellent. So similarly, I did this. Now I'm going to do the opposite one. Because venous O2 concentration depends upon arterial O2 content. Is it? It depends upon arterial O2 content. The blood from arteries, it will go to the veins. Okay. Now, suppose my arterial O2 content is 10 and my venous O2 content is 8. Here, body will have to increase the cardiac output. Is it? Because I have the very low oxygen in the arteries. Is it? So remember, if you want to understand fixed, you have to anticipate it. If you just look at, if you will just look at the fixed principle, and if you don't anticipate it, tomorrow you will forget it. So to anticipate it, you just draw the numbers. First, in order to understand it, first you have to keep one thing in the mind. The oxygen in the veins depends upon the oxygen in your arteries. If you increase the arterial oxygen, then only venous O2 will increase. If you actually, so right, so here arterial O2 is 10, venous O2 is actually 8. So it means difference is 2. So body needs to compensate because arterial O2 content is very low. All right, so that's all about your fixed principle being there. Now after fixed, we discuss the pulse pressure. PPP, pulse pressure. So pulse pressure is actually the difference between systolic blood pressure minus diastolic blood pressure. Okay, so normal pulse pressure will be equals to what? 40, is it? So pulse pressure is actually directly proportional to your stroke volume. If you have the more stroke volume, you get more pulse pressure, and it's inversely proportional to your arterial compliance. If your arteries are, if your arteries are more rigid, more stiff, means more pulse pressure. Okay, so what are the parameters which are going to increase the pulse pressure? So parameters will be those which increase the stroke volume. Okay, will increase the stroke volume or decrease my compliance. Okay, so in what diseases my stroke volume is increased first? Can anybody tell?
Aortic regurgitation.
Very good.
Aortic regurgitation.
Aortic regurgitation, excellent. What else?
Hyperthyroidism.
Yep. Aortic regurgitation, which increase my stroke volume. Very good.
Hyperthyroidism.
Hyperthyroidism, excellent. Very good. Hyperthyroidism.
Anemia.
Hyperthyroidism. Hyperthyroidism. Increase T3. High output heart failure. Very good. High output heart failure, hyperthyroidism, or could be your exercise. Exercise. Very good. So these will increase my stroke volume. So what are the diseases in which my compliance will decrease? Compliance. Age.
Old age.
Aortic stiffening.
Aortic
Stiffening, that is chronic hypertension.
Yeah, aortic stiffening, very good. So when you get aortic stiffening, very good. Aortic stiffening, when you get the chronic hypertension, very good. That's going to also increase my pulse pressure. Okay. And other causes of increased pulse pressure will be your OSA, obstructive sleep apnea, because of more sympathetic drive. More sympathetic drives will be seen in these patients. Okay. Now, diseases in which your pulse pressure is decreased. So these will be the diseases which actually decreases your stroke volume. Or increase your arterial compliance. So what are the diseases in the stroke volume go down? That will be your
heart failure,
aortic stenosis,
heart failure,
excellent.
Cardiac tamponade.
These are the diseases in which you're going to worry. Okay, so these are actually the diseases being there where pulse pressure is going to be. Okay, so now last parameter is called MEP, mean arterial blood pressure. Mean arterial blood pressure means you are taking the mean of the blood pressure, is it? So your systolic blood pressure, high blood pressure is 120, and diastolic blood pressure is actually equals to what? It's actually equals to 80. So any value which come in the middle of this will be called mean arterial blood pressure. So in the middle, what value will come in the middle? That will be around 92 to 93. Is it? 92 to 93 is going to come in the middle. Okay, so it's also called 1/3 of the systolic blood pressure and 2/3 of the diastolic blood pressure. You will get this value. That's called your mean arterial blood pressure. And what is the equation? How do we calculate the mean arterial blood pressure? Can anybody tell me the equation?
2/3 of DBP plus 1/3 SBP.
Yeah, no, that will be the 1/3. Yes. What's the other equation? So mean arterial blood pressure will be equals to cardiac output times total peripheral resistance. This parameter needs to be regulated tightly. You have to regulate it tightly. Okay. So if it decreases, you are going to get what? Your blood pressure will decrease so severely. Okay.
Shock.
Okay. Yep. So we will discuss that shock. We already discussed it a couple of days ago. Okay. All right. So that will be your mean arterial blood pressure. Now we're going to discuss the Starling curves according to the Frank Starling. So what does the Starling says? Frank Starling. Can anybody tell me what does the Frank Starling says? Starling
Force of
length. Contraction is proportional to the length of the fiber.
Exactly. So force of contraction is directly proportional to the preload or end diastolic volume. So according to the Frank Starling, it says that if you give more blood to the heart will actually returns you that much blood. Okay, so it's up to certain limits. Being there. So if you increase, simply Frank Starling says that stretchability is equals to the contractibility. Stretchability is actually equals to contractility of the heart. Stretching is equals to the contraction of the heart. Okay, that should be up to certain limits. And if you after that limit, if you increase the venous return to the heart, it will have no effect on the contraction of the heart. Okay, so I'm going to draw this picture for you. So this is, suppose my curve being there. This is Starling curve, and according to Starling curve, on the x-axis I will have the venous return, or I will say preload, and on the y-axis I will have the stroke volume. So this will be my stroke volume here: 0, 10, 20, 30, 40, 50, 60. And this will be my venous return being there: 0 here, 10, 20, 30, 40, 50, 60. So according to Frank Starling, it's actually directly proportional. So it says that if you keep increasing so look at, this is a curve here. This is curve look like this. So at the venous return of around 50, your cardiac output is equals to 45%. Is equals to 45, or stroke volume is equals to 45. So you see, it's actually directly proportional up to certain limits. If you further increase the venous return, there's no increase in the stroke volume. Why? Because the heart is already contracting at its maximum capacity. So it will not further contract. Okay, so that's all about your Frank Starling's law. All right. Now after that, we have the resistance being there. So resistance is actually, hindrance to the blood flow in the blood vessels. It's called the resistance being there. So what is the equation of the resistance? Resistance will be equals to what? Resistance is actually equals to your change in the pressure or driving pressure divided by your flow. So resistance is inversely proportional to the flow. It means if you have the more flow, your resistance is going to be low. Okay, so resistance equation can also be like this. It's going to be viscosity of the blood. It times the length of the blood divided by your radius, or pi into radius. So according to this equation, if your blood viscosity is more, there will be more resistance. So can anybody tell me what is the name of the disease in which the viscosity of the blood increases?
Polycythemia.
Polycythemia.
Yeah, very good. Polycythemia is there. Very good. Polycythemia, very good. What other
Multiple
Multiple
myeloma.
myeloma.
Excellent. So in the multiple myeloma, polycythemia, you are going to have the increased viscosity of the blood. So can anybody tell me why? How, when you have the more length of the blood vessel, it is more likely to have the more resistance. Why? What's the reason?
Increase red blood cell mass.
Length. When you have the increased length of the blood vessel, how it increases the resistance?
They increase the length, they increase the chances of facing
Exactly.
resistance.
Very good. Excellent. Look at this. So if you have to travel more distance, if you have to travel 10 miles, you are more likely to get the traffic as compared to 5 miles. Okay. So take it like this. Okay. So you get increased length of the blood vessels, more resistance. Radius, if you have the more radius, it means less resistance, because if you have the if your road size, if your road size is bigger, you're less likely to get the traffic. Okay, so that's actually the anticipation being there. Now within the circularity system, there's only one point where you get lot of the resistance, that is called arterioles. At the level of arterioles, you get lot of the resistance being there. Can anybody tell me why? What's the reason?
More
Because of
hydrostatic.
More elastic fibers.
No, why
because of the increased hydrostatic pressure, since it's close to the
Very good.
capillary.
Excellent. Very good. Because you want to increase the hydrostatic pressure here. Hydrostatic pressure should be high here. Hydrostatic pressure, okay? So you want the hydrostatic pressure will be so high here. So that's the reason you want the resistance to be very high at this point, is it? Because it will generate the more pressure, okay? So that's the reason arterioles will have the highest resistance will be there, okay? Now, no need to remember resistance in the series. It's actually more in a parallel. It's just try to anticipate the equations. How you can anticipate the equation in this way, you will remember the things. Now we're going to discuss the pressure volume loops and the cardiac cycle. So I take a just 1 minute break, then I will start the high yield one, pressure volume loops and the cardiac cycles. And after that, we discuss the murmurs and all these things. Okay. All right. So just a 1 or 2 minute break, then we start the pressure volume loops. Okay.
Not able to hear. Okay, thank you.
Okay, so I'm back. All right, so now we're going to discuss the pressure volume loops and the cardiac cycle. So cardiac cycle is composed of what? It's composed of the systole and the diastole. Cardiac cycle is equals to your systole. Systole is a phase during which the left ventricle contracts. This is a contraction happens. Contraction. Okay, so systole is further divided into two phases. What are these two phases in which the systole is divided? Systole is divided into your isovolumetric contraction, which I will likely discuss with you in the graph. Isovolumetric means the volume of blood is going to remain same. Isovolumetric contraction. Okay, and other is called your ejection phase. So systole is divided into two phases. That's called ejection phase. Ejection means the blood will go into the aorta. Okay. Now, what is diastole? Diastole is a phase during which the heart fills. You get a filling of the heart. Heart is going to fill during diastole. Okay. So it's being also classified into two phases. So what are these two phases? You get what? First, the heart will relax, then it is going to fill. Okay. So you will get what? Isovolumetric relaxation means the volume will remain same. Isovolumetric relaxation. And then you get what? Filling. So filling is further divided into two phases. First, you get the rapid filling. That is because of the more pressure difference between the left atrium and the left ventricle. So you get what? Rapid filling. And after that, you get the delayed filling. Once the pressure start to go up in the left ventricle, you get what? Delayed or reduced filling. Very good. So now I'm going to show you the graph, like how these phases are actually divided. Okay. So this will be the graphical representation. So we're going to draw this graph. So this will be your, okay. So that's actually your graphical representation. So I will draw the y-axis and the x-axis being there. So in the x-axis, so this is called pressure volume loops. So now we are drawing the pressure volume loop and the cardiac cycle. So on the x-axis, I will have the left ventricular volume. This is my left ventricular volume. And on the y-axis, we have what? It is called left ventricular pressure. Left ventricular pressure. Okay. So this will be your volume being there. Suppose here, my left ventricular volume is 0, 10, 20, 30, 40, 50, 60. Suppose this is my starting point. This is a point where my systole starts. So what was the first phase of the systole? It was called your isovolumetric contraction. Okay, so this is my pressure being there. Here my pressure was 0. Here pressure is 20, 40, 60, 80, 100, and 120. Okay, so this is the point where my systole starts. So first phase will be called what? From point A to point B, this will be called isovolumetric contraction. So look at this, what is happening in the isovolumetric contraction? The left ventricular volume is actually remaining same, but the pressure is actually increasing. Why? Because the blood is not coming in and not going out of the left ventricle, because every valve is actually closed. Every valve is actually closed. So that will be isovolumetric contraction.
We can't see the full screen. Okay. I don't know whether it's only me.
Okay. So from point A to point B, I get what? Isovolumetric contraction. So after isovolumetric contraction, I will have what? Ejection. So in the ejection, what is going to happen? The left ventricular volume is going to be decreased and little bit pressure also drops. So this is ejection. The red one is called ejection. So ejection is actually completed. I don't know why you can. So can you guys see me? Can you guys see my board?
Yeah.
Yeah.
Yes.
John, there must be a problem, Jones. Today you are here, Jones. Welcome back.
Use the cursor and move the screen so that you can locate where the teacher is drawing.
Exactly.
That's how you can locate it.
Yeah. Okay. So from point B to point C, you get what? You're going to get what? Ejection. This is called ejection phase. So ejection means the left ventricular volume is going to be decreased. So look at this. Left ventricular volume decreases from 50 to 10. And little bit of the pressure also drop. Little bit of pressure also drop. So this is called ejection phase. So here at the point C, what happens? Your systole ends. Systole ends. So ejection will only happen when your aortic valve opens. So here your aortic valve opens. At the point B, your aortic valve opens. At the point C, your aortic valve closes. So after completion of the systole, the diastole will start. So what is the first phase of the diastole being there? We have the blue one that is called isovolumetric relaxation, where you get what? Decrease in the volume of left ventricle. So left ventricular pressure is decreasing, but your volume is remaining same. So this is called from point C to point D. This phase is called what? From point C to point D. This is actually called your isovolumetric relaxation. Okay, isovolumetric. Because volume is remaining same. Relaxation. So pressure is going down and the volume is remaining same. So this is called isovolumetric relaxation. Now after isovolumetric relaxation, you will get another phase which will be called rapid filling, which is I am drawing with a green color. So rapid filling is happening. So look at this, up to 40, you get rapid filling. So this phase from point D to point E, you get what? Rapid filling. Okay, so this will be called rapid filling, and after rapid filling, you are going to get the brown color that will be called delayed filling or reduced filling. From E to A, you get the reduced filling, and once your filling is completed, you get what? You get the again systole will start. So this is called cardiac cycle and the pressure volume loops being there. Okay, so isovolumetric contraction is a period during which the ventricles consume a lot of the oxygen. Lot of the oxygen is actually consumed. Okay, so can I say like this? Isovolumetric contraction is a period between the mitral valve closure and the aortic valve opening, because at the point A, what happens at point A? Your mitral valve closes. Okay, and the aortic valve opens at the point B. Aortic valve opens. So can I say isovolumetric contraction is a period during which your mitral valve between the mitral valve closure and the aortic valve opening is called isovolumetric contraction. So after isovolumetric contraction, you get what? Ejection. So ejection is a period between the aortic valve opening and the aortic valve closure. Is it? That will be called ejection. Okay. All right. So that's actually your pressure volume loops being there. Now area under the curve. If you focus area under the curve, so this is my area under the curve. So area under the curve will be equals to what? It will be equals to the stroke volume. It will be equals to the stroke volume. So how? So remember, very important points coming now. This is the normal pressure volume loops. Now I will discuss the changes in the pressure volume loops. So you guys know that area under the curve is called stroke volume, which will be equals to end diastolic volume minus end systolic volume. So can anybody tell me in this graph, what point indicates end diastolic volume? What point? Point A, B, C, D, or what?
Point A.
Point A.
Very good. Point A is actually your end diastolic volume being there, which is actually 50. Okay. And what points indicates your end systolic volume?
Point C.
Point C.
Point C. Very good. Which is actually 10. So what is my stroke volume in this patient? That will be 40 ml. 40 ml. Now, very easy to understand this. If you change the size of the curve, or if you change the area under the curve, your stroke volume is going to be changed. So suppose if you change the size of the curve, if you lead to the swelling of the pressure volume loop in the rightward direction, like in this direction. So normally the start point is A. So instead of starting from A, I start at this point. I start at the F point. F is a point where my systole starts. So what will happen if my systole starts at the F? My area under the curve will increase. Is it? Look at this. My area under the curve increases. So if you increase the area under the curve, your stroke volume will increase. So that increase can be in the rightward direction or in the leftward direction. If I increase the area under the curve in the rightward direction, I increases the end diastolic volume. And it's only possible when I actually increase the preload. Okay. When I increase the preload, that will actually increase your end diastolic volume. Okay. So, and I can also increase the area under the curve by shifting my point C. So I can shift my point C towards the point G, this. So this will also change my curve size. So I shift it in the leftward direction. So when I shift it in the leftward direction, what I'm doing, I'm decreasing the end systolic volume. So can anybody tell me what situation or what condition will actually shift my pressure volume loops from the point C to point G? Yep.
Heart failure.
Heart failure?
Mitral stenosis.
No. You see, I'm changing the point C to point G. It means I'm decreasing the end systolic volume. Is it? Now,
Exercise.
exercise could be there. Very good, because it means you increase the contractility. You increase the contractility of the heart. So when you increase the contractility of the heart, the pressure will increase, plus the left ventricle ejection will also increase. So your end systolic volume is going to be dropped. Okay. So end systolic volume drops and your stroke volume will increase because area under the curve will increase. Okay. So this is how you increase the stroke volume. You can increase the stroke volume by increasing the preload, by giving the IV fluids, or you can increase the stroke volume by actually decreasing the end systolic volume, which is only possible when you increase the contractility of the heart. When you increase the contractility of the heart, so this is how your pressure volume loops can be changed. Now, what will happen to my stroke volume if I increase the afterload? If I increase the afterload, what changes I will see in the pressure volume loops? Anyone?
Stroke volume decreases.
Increase aortic pressure.
Very good. Your left ventricular pressure will increase, but left ventricular volume will decrease. Okay, ejection will decrease. So the pressure volume loops will look like this. Okay, so your pressure is going to be increased like this, going up, and this will be area under the curve is going to be decreased. So this will be the afterload being increased. Afterload. Okay. Afterload is going to be, okay. So this is how you increase your afterload. When you increase the afterload,
Can you please repeat, please? Sorry.
No, yeah, sure, I can repeat it. Yeah. So if you increase the afterload, what will happen to the pressure volume loops in the left ventricle? Okay, so pressure volume is going to get shrink. The size of pressure volume loops will decrease. Why it will decrease? Because less amount of blood will go into the aorta. Is it? So less blood in the aorta. So your left ventricular pressure will increase, but left ventricular volumes will decrease. Is it? Stroke volume will decrease. So this will be the size of the pressure volume loops. Pressure volume.
Sir, would it affect the cardiac cycle? Like cardiac cycle would be fast or slow?
It will be slow. I mean, cardiac cycle is not going to be affected, but only pressure is going to be increased. So left ventricular contractility will increase. Is it? Simply left ventricular. Your cardiac cycle duration will only be affected when you increase the heart rate. When you increase the heart rate or decrease the heart rate, then only your cardiac cycle duration will be affected. But I don't think so, because when you get increased afterload, it's going to reduce the heart rate. You know, vasoconstriction is your bradycardia. So I don't think so it's going to affect your cardiac cycle duration. Okay.
Thanks, sir. I appreciate it.
Okay, no problem. Okay, so that's actually your pressure volume loops and the left ventricular contractions. All right, now we can actually hear some heart sounds being there. So S1 heart sound is actually due to what? S1 heart sound is actually due to the Cloyer-Watt valve. It's due to the Cloyer-Watt valve. It's due to the Cloyer of mitral valve or tricuspid valve. S2 is due to the Cloyer-Watt. It will be due to aortic valve. Aortic valve. So there are some pathologies or physiological conditions where we hear the extra heart sounds. Extra heart sounds means it will be your S3 and the S4. So first we discuss the S3 heart sound. They're also called the hot scallop heart sound because their intensity is similar to the horse running. Horse running being there. So S3 heart sound is only seen when you have the volume overload state in the ventricles. Volume overload state. And why volume overload state causes the S3 heart sound? Because you see, S3 is actually produced when the two blood strikes with each other. When the blood from the left atrium and the left ventricle, they collide with each other, they will produce a sound that is called S3. So it's being produced due to the collision of the blood. Collision of blood. When they collide with each other, you hear the heart sound. That is and the collision is only possible when your blood is actually staying within the left ventricle. Okay. So can anybody tell me what are the physiological conditions in which the volume of blood increases in the left ventricle that will lead to S3? Yes, physiology.
Heart failure.
I asked the question physiology.
Early pregnancy.
Very
Pregnancy.
very
Pregnancy.
pregnancy. Very good. Pregnancy. Very good. Growing child. Very good. Growing child. Pregnancy. Very good.
Athlete.
Athlete. Very good. These are the physiological conditions where you hear. Now, pathologies which leads to stasis of the blood in the left ventricle. What are these pathologies? Very good. Mitral regurgitation. Excellent. Aortic regurgitation. Very good because of the backward blow. And last will be your heart failure.
Heart failure.
Yes, or thyrotoxicosis. Very good. It can also be thyrotoxicosis because it will lead to high output heart failure. Okay. So
Even severe anemia, which is not treated.
severe anemia. I don't know. That will lead to high output. Yes, it can produce S3. You're right. High output can be there.
Beriberi? Is it beriberi also?
Yes, beriberi. You're right. Any disease which causes high output heart failure will actually lead to your
AV fistula?
AV fistula. Very good. Very good. You remember that class. Good job. Very good. Okay. So, all right. So S4. Now S4 is actually here when you're the pressure overload state. Whenever you're the more pressure. Very good. Still pressure overload. So S4 is
S4.
always pathologic except aging. So what are the pathologies in which you are going to hear the S4?
Atrial stenosis and uncontrolled hypertension, chronic.
Aortic stenosis, very
failure.
aortic
And
hypertension,
Hypertrophic cardiomyopathy.
very
chronic.
good.
Yeah.
Very good. And what's the cause of S4? S4 is actually produced by atrial kick. When your atria trying to kick the blood. Why atria is going to kick the blood? Because pressure is so high in the left ventricle, atria have to produce their efforts. And in producing these efforts, they will actually produce a sound that will be called your S4. Okay. So that's all about your S4 heart sound we hear. All right. Now we're going to discuss the JVP being there. So JVP is actually the pressure recording of the right side of the heart, especially it records the pressure changes in your right atrium. So JVP has the 3 waves and the 2 descents. 3 waves are actually present in the JVP, which are called high pressure waves being there. So this will be your first wave in the JVP, which is called A wave.
A wave.
A wave is actually there. So this A wave is actually produced due to what?
Atrial contraction.
Very good. It produced due to atrial contraction. So when you get atrial contraction, it's going to produce your A wave. Very good. Atrial depolarization or atrial contraction. Very good. So can anybody tell me in what disease A wave will be absent in the
Atrial fibrillation.
Very good. Fibrillation. I already discussed why fibrillation. I already discussed with you guys that because you don't get a proper depolarization in the atria. Okay, so there's no peak in the atrial fibrillation. So A wave, in what disease you are going to get the prominent A wave? I mean to say Cannon A wave. Prominent means very thick A wave.
Tricuspid.
Can anybody justify why? How AV dissociation will produce thick A wave?
There is
Yep. AV dissociation means what? First, try to explain me what is AV dissociation.
Atrium is contracting, ventricle is not dilating. I mean, there's no association between atrium and ventricle.
They are both independent from each other.
They are not synchronized.
Yeah, not synchronized. Excellent. Very good. So if they are not synchronized, normally the contraction and the pressure in the right atrium is regulated by pressure in the right ventricle. So there's no proper regulation. So atria is going to generate a lot of the pressure that will be reflected at very thick airway being there. Okay. So after atrial contraction, what events will happen? So you have to, in order to understand the JVP, you have to follow the sequence of the events happening in the right atrium and the happening in the events happening in the right atrium. So after right atrial contraction, what will happen next? You will actually get another wave that will be called C wave. This is also pressure wave. So this also indicates high pressure in the right atrium. So C wave is actually produced due to right ventricular contraction.
Contraction.
Now you guys must be thinking how right ventricular contraction will increase the pressure in the right atrium. Yep.
It will go back and pressure will be closed valves.
Exactly. So what will happen? What's going to happen when you have the right ventricular contraction? What is going to happen? Your pressure in
Tricuspid valve
tricuspid
trying
valve,
to push into the paper.
your tricuspid valve is going to bulge into the right atrium. So that will decrease the size of the right atrium. Okay, so pressure is going to be increased. So after this, what event is going to happen? The right atrium is going to relax. So if your right atrium relax, the pressure is going to go down, is it? So which is going to produce your X descent. X descent. Okay. Is my sound good to you guys, or or it's breaking?
No, it's good.
It's good.
It's
Okay.
good. It's good.
Thank you. Okay. So what is going to happen? You are going to get X descent. Now X descent is actually low pressure. The pressure is getting lower because right atrium is relaxing. So relaxation means X descent. Okay, this is due to relaxation. Now, in what diseases this relaxation wave is actually absent or it's not being present? I don't see this relaxation. Means the pressure X descent absent. What does mean by the absence of X descent? Means the pressure doesn't go down in the right atrium. No pressure drop in the right atrium means absent X descent. So in what disease the pressure never goes down in the right atrium? The right atrium doesn't relax properly. Yep.
Right heart failure.
Very good. So one disease will be tricuspid regurgitation because tricuspid regurgitation will always allow the blood to go into the right atrium. So right atrial pressure never drops. Okay. So X descent is going to be absent. And second disease will be right ventricular failure. When you get right ventricular failure, the pressure in the right ventricle is so high, it will allow the backward movement of the blood. So blood is going to stay within the right atrium. So right atrium doesn't relax at all. Okay. So that's why X descent is going to be absent. Okay. So after complete relaxation, what will be the next event in the right atrium? They're going to fill. They're going to fill. So when they fill, the pressure is going to go up. That is going to produce a V wave.
V wave.
V wave, very good. So V wave is actually going to be produced, and this is due to your filling of the right atrium against your closed tricuspid valve. And after they completely fill, they will actually empty themselves, which will produce a Y descent. Y descent. So Y descent is again a low pressure wave, okay, which is due to emptying being there. Now, can anybody tell me in what disease your Y descent is so prominent? It means there's a more drop in the right atrial pressure. It means more prominent. In what disease you are going to get the prominent one?
Constrictive pericarditis.
Could you please tell me, Asif Khan, why? Why constrictive pericarditis will lead to more drop in the right atrial pressure? Yep, why?
Because it cannot.
Due to the fibrosis.
Filling is problem because
Yeah,
of
I told you. I already told you guys in the class. I want answer from you guys. Okay, a lot of the students I see here today over in my class, and they should answer me because I explained JVP very quickly and in the details. We are just reviewing. I'm sorry to my new students. I'm so quick. Otherwise, this is not my pace. Okay, my pace in the usual classes is very slow. Okay, all right. So, yeah, constrictive pericarditis. Why? Why in constrictive?
Due to the fibrosis, the right atrium has to generate higher force to push the blood out into the right ventricle.
It's equal pressure from all the sides.
Excellent. Constrictive pericarditis means you get very rigid pericardium. So right atrium will do what? Right atrium have to empty themselves. So they will do everything to empty themselves. So they become what? Right atrium become more emotional, is it? It become more emotional, and in doing so, it produce a lot of the efforts and it generate a lot of the pressure being there. So it actually empty them completely because it generate a lot of the pressure. Okay, so this is actually their constrictive pericarditis, and it's going to be absent in the cardiac tamponade because in the cardiac tamponade, the pressure will never go down in the right atrium. Why? Because there's a lot of the fluid outside in the heart. Okay, so that was all about JVP. Now we will discuss the pressure volume loops and the your valvular heart diseases. So first, a valvular heart disease we discussed is called aortic stenosis. So in aortic stenosis, what will be your pressure volume loops? I mean to ask, the parameters will be here. So what is going to happen to the end systolic volume in case of aortic stenosis? Anyone? It's going to be increased. Why? Why? It's going to be increased. Yes. Why? Why? What is end systolic volume? End systolic volume is the amount of blood which remains in the left ventricle after the completion of the systole. Is it? If you get aortic stenosis, means more resistance in the aorta. So left ventricle cannot eject much blood. So more end systolic volume will be there. Okay. All right. So what is going to happen to the end diastolic volume? Anyone? End diastolic volume. End diastolic volume.
No change.
No change because it's related to the diastole. It's not related with the systole. Okay, and obviously your stroke volume is going to be decreased. And what will happen to the end diastolic pressure?
Increase.
Why?
Increase.
Why? Why?
Because of
As
increase in afterload.
stroke volume.
Yes. Can anybody tell me? I already told everything in the class. Yeah. This is just a quiz for you guys. Bootcamp should be the quiz for the students. It should not be, tutor should not be teaching. Students should be teaching to the tutor and its colleagues. Is it? Yeah.
As it increase in systolic volume, that means more blood in the heart and it causes the more pressure.
End diastolic volume is end diastolic pressure is going to be increased because in aortic stenosis, your left ventricular cavity size decreases. Left ventricular cavity size decreases. Okay, so look at this. This is example, very simple example. Suppose this is my one left ventricular cavity. Left ventricular cavity is there. This is my one left ventricular cavity. And size of this left ventricular cavity is what? This left ventricular cavity is 8 centimeter. And I am putting 16 ml of the blood here. 16 ml of the blood in the 8 centimeter cavity. And similarly, this is my another left ventricular cavity, which is after my aortic stenosis patient. This is actually my 4 centimeter cavity. This is 4 centimeter cavity. 4 centimeter cavity. And here I am also putting how much? I am putting the 8 ml. Sorry, I am putting the same 16 ml. Because I didn't change my end diastolic volume. So pressure is going to be very high in the 4 centimeter cavity or 8 centimeter cavity.
Second one.
Yeah, second one, obviously, because the size is low. That is why the end diastolic pressure increases. Okay. Okay. Now we're going to discuss aortic regurgitation and the parameters. Regurgitations. So aortic regurgitation is actually what? Aortic regurgitation means the aortic valve doesn't close properly. So if it doesn't close properly, so what will happen to my end diastolic volume? Yes.
Increase.
Why?
To increase.
Why?
Because blood pushed from aorta to the left ventricle.
Excellent. Very good. So two bloods are coming. One from the left atrium, another from the aorta. So it's going to be increased. Yes. What will happen to the stroke volume?
It would increase.
It will increase because according to Frank Starling. Frank Starling, very good. And there will be no true isovolumetric phases, okay? So that will be your aortic regurgitation for you. Now, other is called mitral stenosis. So mitral stenosis, so parameters are there. So what is going to happen to my end diastolic volume in the mitral stenosis?
Decrease.
Decreases because the blood is not coming from atria to the ventricles, okay? So what will happen to the stroke volume?
Decrease.
Decrease. Frank Starling, very good. And what will happen to my end systolic volume?
Decrease.
Why? Very good. Decrease, but why?
As blood coming less blood coming, so end systolic volume will be less, and there is no problem with
Exactly. So you have the less blood being coming. So it's a more, so left ventricle will try to increase ejection fraction. So it will increase its contractility. So your ejection fraction is going to be increased and the end systolic volume will be decreased because contractility is increased here. Okay. All right. So that will be mitral stenosis. Now mitral regurgitation. Mitral valve doesn't close properly. And if the mitral valve doesn't close properly, what is going to happen to my end systolic volume here? Yes.
Increases.
Decreases. Why?
Backward flow.
Because the blood is going in the two direction. One in the forward direction in the aorta, another in the backward direction in the left atrium. So your volume at the end of the systole is going to be obviously decreased. Okay. So what is going to happen to your end diastolic volume?
increase.
Why?
Increase.
Because the blood is actually coming.
Increase.
Blood is actually coming from the two. So two bloods are coming to the left ventricle during diastole. The one which go to the left atrium from the left ventricle, another blood coming from the pulmonary vein. So they will combinedly come to the your left ventricle. Okay, so what will happen to the stroke volume?
Increase.
Very good. Why?
Because there's
More
more
blood is
EDV.
coming in two
More
different
blood is
directions.
coming.
So
More blood.
blood is going in the two direction. One into the aorta, another is going into the left atrium. Okay. So stroke volume means the blood going out of the left ventricle. This is the output of left ventricle, either in the forward direction or the backward direction. Okay. So this is going to be increased. All right. So that was all about these changes and the valvular
The
disease.
backward flow of the blood is called a stroke volume again.
Yeah, it's called stroke volume. Stroke volume means the blood going out of the left ventricle, either in forward or backward. We don't care. Okay.
Okay, if there's a MR and MR blood goes into the left atrium, so it is also called the stroke volume sometimes.
It's also called a stroke volume. It's called the backward stroke volume, not a forward one.
Okay,
Forward.
thanks.
Okay. So now splitting of the heart sound. Splitting means you get the breakdown of the S2 heart sound. So we get physiological splitting because of the respiratory cycles being there. Okay. So with inspiration, we get the splitting with inspiration. So with inspiration, what happens with inspiration? You get the delayed closure of the pulmonic valve. And you see aortic valve will be closed here. This will be my A2 component. And this will be my 4 seconds of the delayed normal. This is called P2 components. So with inspiration, the P2 is actually closed late. Closed late, this is called 4-second delay. And that will produce a splitting, which is called your physiological splitting. And can anybody tell me why? What's the reason with why? Why are the P2 closes late with the inspiration?
Because increase
Intrathoracic pressure.
Because inspiration will generate negative intrathoracic pressure, is it?
Yeah.
Intrathoracic pressure. Intrathoracic pressure is going to be negative with the inspiration. So what will happen? You will increase the venous return to the right side of the heart. And when you increase venous return to the right side of the heart, it will lead to what? Delayed closure of the pulmonic valve. Delayed closure. Okay. So you get delayed closure of the pulmonic valve because more blood will be going to that direction. Okay. So this is called your physiologic splitting, which we discussed already. That was just brief review being there. Now, after that, we get the wider splitting. Wide means you get the exaggeration of the normal physiological splitting. So normally with inspiration, you were getting what? Normally with inspiration, you will getting 4-second delay, but in wider splitting, you are going to get the delay of double delay will be seen. Now here A2 component will be here. This will be my A2. And this is going to be my delay. This will be my P2. The delay is actually 8 seconds. Double. Delay is actually double. So wider splitting means your P2 is more delayed. Means the right side of the heart is getting slower. So what are the pathologies in which I will get the wider splitting? Anybody? What pathologies will lead?
Pulmonary stenosis.
Pulmonary stenosis, very good. Pulmonary is not
Right bundle branch block.
right bundle branch.
Pulmonary hypertension.
Right bundle branch block, because these pathologies will slow down your right side of the heart. So A2 component will come, not AST. AST is something different. I'm going to discuss that. So wider splitting is an exaggeration of the normal physiology. Splitting is called wider splitting. Okay. Now we are going to discuss the fixed splitting. Fixed splitting means you are getting the same amount of the delay. You get same amount of the delay with inspiration and the expiration. So fixed splitting means it is not changed with the respiratory cycle. Fixed splitting. Fixed splitting. So you get the same delay with the inspiration and the expiration. Suppose with inspiration, normally you are getting what? Normally with inspiration, you are getting 4-second delay, which was my normal physiologic delay. This is my inspiration. Okay. This is inspiration. 4-second delay is exactly there. Now I also get the delay here with the expiration as well. Normally I don't see the delay with the expiration, but here in fixed splitting, I'm getting the delay with expiration. So this is my A2 component. And this one is my P2 component. So same delay of 4 seconds is also seen with the expiration. And this delay is, this fixed splitting is only seen is only seen in the AST. Can anybody tell me why? What's the reason? I already discussed that.
Yeah, because blood is going from left atrium to right atrium. During expression, left atrial pressure is more than right atrial pressure.
Very good. Good job. Excellent. Very good. So with expiration, what happens? The pressure in the left atrium goes high. Is it? So if your pressure in the left atrium goes high with the expiration, there will be more shunting of the blood to the right atrium. And if you shunt the more blood from left atrium to right atrium, the more blood will go to the pulmonary artery. And if you send more blood to the pulmonary artery, it will take more time to close. Whereas with inspiration, the opposite can happen. With inspiration, the pressure in the right atrium goes up. So it is equals to your pressure in the left atrium. Okay, even right atrial pressure can be higher than the left atrial pressure because there's already more blood coming to the right atrium. So we don't see the shunting during inspiration in the ASD patient, but during expiration, we get the shunting, which will lead to the fixed splitting. Okay, so fixed splitting means same amount of the delay you see in the closure of the pulmonic valve with inspiration, the expiration. That's why it's called fixed splitting. Okay, now we have the paradoxical splitting being there. Paradoxical means opposite. The term paradoxical means opposite. So in paradoxical splitting, what happens? Normal physiological splitting is what? You are in the normal physiological splitting, you are getting the delay. In the normal physiological splitting, you get the delay with the inspiration. But here in paradoxical splitting, you get the delay during expiration. There's no delay with the inspiration. And you see, this will be my expiration. So you get the delay in the expiration. This is my P2 component. P2 component comes first. Okay, and the A2 component is delayed. This is my A2 component. So with expiration, I'm getting the 4-second delay. Okay, this is called paradoxical splitting. With inspiration, what happens with inspiration? With inspiration, what happens? Your P2 is always delayed. Your P2 is normally delayed, so P2 will go close to the A2. So you hear with P2 will be here, and this will be my A2. So look at this. I don't get the splitting with inspiration, which is normal physiology splitting. Here, I'm getting the splitting with the expiration. That's called paradoxical, opposite to the normal. So any pathology which slow down your left side of the heart will lead to paradoxical splitting. So that will be your aortic stenosis and the left bundle branch block. Okay, so that's actually all about your splitting being there. All right, now we're going to discuss the heart murmurs. So we're going to jump into the heart murmurs being there. Okay, heart murmurs. Okay, murmurs of the heart. So murmur is any extra heart sound which is produced due to the turbulence of the blood flow. When the blood flows is turbulent through the valve, it is going to produce a murmur and it's an extra heart sound. So the location of the murmur depends upon the direction of the blood flow. Where the blood is actually flowing, so that will be the location of the murmur. So first we discuss the aortic stenosis murmur. AS. So aortic stenosis murmur is actually what is the characteristic of aortic stenosis murmur? It's actually crescendo, decrescendo, ejection murmur. So first we are discussing the systolic murmurs, then we will discuss the diastolic murmur. So this systolic murmur is actually there. So first systolic murmur is called aortic stenosis, which is being heard. So all systolic murmurs will be heard between S1, which is the closure of the mitral valve, and S2. S2. So aortic stenosis murmur is a crescendo decrescendo murmur. What does mean by crescendo decrescendo murmur? Initially, it will increase gradually in the intensity, like this. It increases gradually in the intensity, then it decreases in the intensity gradually, like this. So you get what? Gradual increase, then you get the gradual decrease. That will be called crescendo decrescendo ejection type murmur, which we hear in the aortic stenosis, and it's very loudest at the base of the heart. Base of the heart means it will be very loudest at the second right intercostal space. Second right intercostal space. And can anybody tell me why aortic stenosis murmur is here at the right intercostal space? The aorta should be on the left side, is it?
Arch of aorta.
Because of the trend, your arch of aorta is going to make a U-turn being there.
U-turn.
Exactly, it's going to make a U-turn to your right side. Okay, so what are the causes of aortic stenosis murmur? Can anybody tell me the causes?
So age.
Aging.
Very good. If it is actually seen greater than 60-year-old patient,
Aging.
normal aging will be there.
Premature aortic stenosis is also seen.
Most commonly due to
Syndrome.
Bicuspid.
yeah, it's
Turner syndrome.
let me
Turner
complete.
syndrome.
I ask one question, you guys.
Oh, is it your company that is doing this stuff?
Wait. Don't get more emotional.
Okay.
Wait. Okay. Okay, if it is greater than 60, it is due to age-related calcification. Age-related calcification. Age-related calcification. Greater than 60, age-related calcification being there. Now, if it is seen as this,
Okay.
okay, and if it is actually seen in the patient who's less than 50 or less than 60, it will be due to bicuspid aortic valve. Okay, bicuspid aortic valve is actually seen in the Turner syndrome. All right, so that's going to be seen in the Turner syndrome patients being there. All right, now younger patients is due to early onset calcification. It's still due to early onset calcification, or it could be due to your bicuspid aortic valve. All right, so how the patient is going to present symptoms?
Syncope, dyspnea.
Syncope, angina, and dyspnea.
Syncope, angina, yeah, very good. You get decreased blood flow to the brain, syncope, you will get decreased blood flow to the heart, angina, and other is called dyspnea being there. All right, so that will be the typical.
Decreased blood of the lung.
Exactly, very good. Very good. Appreciate it. Okay. All right, so now one type of the pulse which you hear in the aortic stenosis is called your pulsus parvus intartus. It means you are going to get a weak pulse with a delayed peak. Weak pulse with a delayed peak, that will be here, okay? Now, other type of the holosystolic murmur, we hear the holosystolic. Term holosystolic means the intensity is going to remain same throughout the systole. Holosystolic. So holosystolic murmur here is called your ventricular septal defect or tricuspid regurgitation. Okay, ventricular septal defect or tricuspid regurgitation, they are what? They are holosystolic murmur being there. VSD is there, and the tricuspid regurgitation is there. And other type of holosystolic murmur we hear is called mitral regurgitation. Okay, the mitral regurgitation. So first we discuss mitral regurgitation. Now, mitral regurgitation is actually loudest at what area? At the apex of the heart.
Apex.
Apex of heart. Okay, which is the fifth intercostal space being there, and it radiates where? It radiates to the axilla. Okay.
Axilla.
Very good. So, what are the causes of mitral regurgitation? Anyone?
Rheumatic
Very
heart
good.
disease.
Rheumatic fever. Very good.
Post MI.
Very good. MI. Excellent. Because it will cause the rupture of peppery muscle. Very
Yeah.
good. Yeah.
Mitral valve prolapse.
MVP. Very good. LV dilation. Excellent. Which will stretch the peppery muscles. Good job.
Infective endocarditis.
Infective endocarditis, very good. Okay, very good. Which will produce the vegetations. Okay, so these are the cause of mitral regurgitation, which will produce your. And how does the patient will present with the mitral regurgitation? He is going to present dyspnea, shortness of breath, fatigue, and pulmonary edema will be there. All right. So other is actually called tricuspid regurgitation. So what are the causes of tricuspid regurgitation? First, what is the location of tricuspid regurgitation murmur? It's being here at the tricuspid area, which is the fourth intercostal space.
Fourth.
Along the left axial border. Okay. All right. So, what are the causes of this tricuspid regurgitation? It will be due
IV drug use.
IV drug use. Very good. Excellent. IV drug users will be there. Okay.
I think
Or
that's carcinoid.
carcinoid. Very good. That was my next question from you guys. Good job. Carcinoid. Very good. Carcinoid. Yes, it's being recorded. Yeah. Carcinoid being there. Okay. Now, what are the other ones? Very good. So, what are the other? Right ventricular dilation, because it will stretch the tricuspid valve. Okay. So, these will be the tricuspid regurgitations and murmurs being there. And patient with tricuspid regurgitation, how are you going to present? How tricuspid regurgitation patient present? Yep. What will be my JVP finding? JVP findings.
Absent X descent.
Absent X.
Very good. Excellent. Very good. Good job. Excellent. So this is actually tricuspid. Now other murmur is called VSD. So VSD murmur is also holosystolic. It's being here at the tricuspid area. Is it? Tricuspid area. So how will you differentiate between VSD and the tricuspid regurgitation murmur? The location is age of the patient. The VSD is common in the children's, and the tricuspid regurgitation is very common in the IV drug users. Okay, so that will be harsh. VSD murmur is going to be very harsh murmur. Okay, it's congenital, and larger VSD will have the lower intensity of murmur as compared to the smaller VSD being there. Okay, and other type of systolic murmur is called MVP, mitral valve prolapse, MVP. So MVP means the mitral valves are very weaker wall, weaker, they are very floppy. They are floppy mitral valves being there. So you hear the MVP murmur at the apex of the heart, and it's very loudest just before the closure of the aortic valve, because the pressure is so high in the left ventricle, just near to the S2 heart valve or just near to the closure of the aortic valve. So what are the causes of the MVP murmur? Yeah.
Collagen.
Very good.
Marfan.
You get the Marfan syndrome or myxomatous connective tissue
Myxomatous connective tissue.
Marfan syndrome, Ehlers-Danlos syndromes, which makes the mitral valve weaker because there's no support available to the mitral valve. Okay, so that will, and other causes could be due to rheumatic fever or
Rheumatic fever. Yeah.
because or you when you get the disease which rupture your chorda tendineae.
Yeah.
Cordia rupture. Okay, so these will be the diseases which are actually causing this. All right, so mitral valve prolapse being there. Now in the mitral valve prolapse, you hear what? Mitral click, then you hear the murmur. So mid-systolic mitral click you are going to hear, which is due to what? Which is actually due to the sudden stoppage of the mitral valve contraction. So when your left ventricular pressure increases, mitral valve is going to produce a click, like click. So these clicks are going to be heard due to the sudden tensing of the coda tentonii. Okay. All right. So that was all about your systolic murmurs. Now we hear the diastolic murmurs being there. So diastolic murmurs, they will be always heard after S2. Any murmur which you heard after S2 heart sound, that will be called diastolic murmur. So we have the diastolic murmur that's called aortic regurgitation. Now, aortic regurgitation is very easy to identify. It's actually decrescendo, high-pitched blowing murmur. Decrescendo. Decrescendo means its intensity is going to drop. Its intensity is going to drop. That will be called decrescendo one. And why the intensity get dropped? Because of the pressure difference. As the blood flows into the left ventricle, the left ventricular pressure increases. So the murmur intensity will drop because the flow will decrease. Okay. And it's what's the location of aortic regurgitation murmur? It's being heard at the right second intercostal space. If it is due to what? If it is due
Root.
to food pathology, if it is through your valvular diseases, it's being here at the left external border, which is the third intercostal space. Okay, so what are the causes of aortic regurgitation murmur? Anyone?
Endocarditis.
Tricuspid aortic valve.
Yes, very good. So causes can be
Aortic root dilatation.
yep, aortic root dilation. Very good. One is that. Very good. What else? Rheumatic fever should always
Rheumatic fever.
rheumatic fever. Very good because it will affect every valve. Okay, or endocarditis can be there. All right. So what will be the presentation of these patients' symptoms? That's important to identify. Symptoms. You might get
Head bobbing.
wide pulse pressure. Very good, Asif Ali. Why? What's the reason? Why do you get the wide pulse pressure? What's the cause of this? Because systolic blood pressure is very high and the diastolic
Very high.
diastolic blood pressure is low because diastolic blood pressure depends upon the resistance in the aorta. Resistance in the aorta. So systolic blood pressure is going to be very high. Okay. Systolic blood pressure is high and the diastolic blood pressure is going to be low because there's no resistance being there. So you get the wider pulse pressure being there. So because of this wider pulse pressure, you might get the different types of the pulse, like you might get the water hammer pulse. Water hammer pulse. So what is water hammer pulse? Water hammer pulse means when you actually try to feel the radial pulse in the patient's arm, your fingers will lift away with the force. You will get the forceful lifting of your fingers from the radial artery. Why? Because of the high pulse pressure. You will get water hammer pulse or pistol shoot pulse. Pistol shoot pulse can be seen. And because of the pulse pressure, you get a Quinsky's pulse, which is called, you will feel the pulses in the nails of the patient. Normally, we don't see these pulses, okay? So that will be your hyperdynamic circulation is actually happening. Hyperdynamic pulse you are going to get. And you see with the advanced aortic regurgitation, you will get head bobbing. Head bobbing means patient's head is going to drop with every systole, the patient's head is going to drop. You get the head bobbing. Why? Because left ventricle is actually ejecting the blood with a high pressure. High pressure that will actually produce the head bobbing. And this head bobbing is going to be seen in case of advanced and the severe aortic regurgitation. So what will be the complication of aortic regurgitation? Can anybody tell me the complication?
Systolic heart failure.
Very good. You get what? Systolic heart.
Left heart.
Very good. Because of volume overload state, you will get dilated cardiomyopathy, then it's called systolic heart failure. Excellent. Very good. Now coming to the another diastolic murmur, which is called your mitral stenosis, MS. So mitral stenosis murmur is also heard at the apex, and mitral stenosis murmur will produce an opening snap. Opening snap followed by your late diastolic murmur. Late diastolic murmur, that is called your mitral stenosis, opening snap. So what is the cause of opening snap we hear? Opening snap is actually due to your abrupt stoppage in the mitral valve leaflet motion. After its rapid opening, your leaflets are fused at the tip. They are fused at the tip, so that's going to produce the opening snap. And after opening snap, you are going to get what? Delayed rumbling diastolic murmur. Delayed rumbling. rumbling diastolic murmur. Murmur. Okay, delayed rumbling light diastolic murmur is going to be heard. Now, severity of mitral stenosis can be seen. Your mitral stenosis will be more severe when the interval between opening snap and the murmur decreases.
Decreases.
Because that's going to increase. That indicates the mitral stenosis is very severe. Now, what are the causes of mitral stenosis?
A
Yes,
rheumatic fever.
very good. Very good. It should be on your
Chronic.
Rheumatic fever. Very good. What other disease?
Endocarditis.
Endocarditis. Very good. Endocarditis, not AFib. AFib can be the consequences of mitral.
Consequence.
Yeah. So these are the two diseases, infective endocarditis and the rheumatic fevers being there. Okay. And all right. So how the patient will present symptoms of the patient with mitral stenosis? Yep.
Dysphagia.
Cornet syndrome.
Yeah. Dysphagia, Ordner syndrome, hoarseness.
Cornet syndrome.
Very good. Pulmonary edema. You might
Hemoptysis.
Heart
hemoptysis.
failure.
Very good. Hemoptysis can be there. Very good. Excellent. And you might get the atrial fibrillation because of left atrial dilation being there. Okay.
And the stasis of the blood.
Exactly. Stasis. So you might get what? You might get the thrombus formation. Okay.
Thrombus formation.
Thrombus and the arrhythmias. Okay. Now,
PVA.
last murmur, which is called continuous murmur, means which is heard throughout the systole. Continuous murmur. Yes, continuous murmur. Continuous murmur means you are going to, there's only one murmur which is heard between systole, diastole,
PDA.
PDA. Pedal ductus arteriosus, and the location of pedal ductus arteriosus is actually what? It's left infraclavicular area.
Machine-like.
Machine-like, very good. So what are the causes of PDA murmur? Causes?
Rubella.
Rubella.
We already discussed these causes, okay? So now,
Premature.
yeah, yes. Now we're going to discuss the action potential in the heart. So action potential in the heart is divided into two types, myocardial and the nodal action potential. So first we discuss myocardial action potential. Myocardial. So myocardial action potential is divided into the four phases being there. So resting membrane potential is actually minus 85. This is the point which is called minus 85. So this is here the heart is actually resting. Now what will happen when your sodium ions go in? It will lead toward upstroke. The potential will go in the positive direction. So this is a point that is called zero. The point of the potential which is called your 0 millivolt. Okay, 0. So potential is going up. This is called phase 0. Phase 0 is due to the opening of the sodium channels. So sodium will go in and it will brings the potential from minus 85 to plus 10. Okay, sodium goes in. All right. So this is called the phase 0, which is due to the rapid upstroke, and this is also called the depolarization. Okay, depolarization means you're actually changing your resting membrane potential towards the positive end, going to the positive end, and that's because of the sodium going in. Now, after you reach to the plus 10, your sodium channels will close. It will lead to the opening of the potassium channels, and once your potassium channels open, what will happen? The potassium will go out of the cell. And I told you why potassium goes out of the cell, because inside the cell there's a lot of the potassium, and outside the cell there's less potassium being there. So you will get what? Blue phase. This is called phase 1. So phase 1 is actually your early repolarization. It's called early repolarization. So here, early repolarization, it means your potential is dropping to the negative side again. So it becomes plus 5. So here you get what? Early repolarization. Okay, early repolarization, which is called phase 1. That's because of potassium efflux. Now what happens when you reach to the plus 5? Another channel will open again. The name of that channel is called calcium channels. So what will happen when the calcium channel open? You will get the plateau phase. This plateau phase means there's no change in the potential, which is called phase 2. So plateau phase, there's no change in the potential because the positive ion is coming into the cell, which is called calcium, and the positive ion is leaving the cell. So there will be no net change in the potential. Plateau phase being there, which is actually specific for the cardiac cells. And after the end of the plateau phase, the calcium channels will close, but potassium channel doesn't close. So it will lead to the late depolarization, which will be your phase 3. Okay, the red one is called phase 3. And this is called your, so cell maybe returning back to is minus 85. This is called phase 3. Okay, phase 3 being there. Phase 3, which is due to the potassium channels being open, it will allow the potassium to go out, sorry. Now, in sometimes during cardiac cycle, your membrane might get hyper repolarized. It might go a little bit down and the potential might go to minus 95. That will be called your phase 4. Phase 4 is actually due to the delayed closure of the potassium wall. So that will be called hyper repolarization. Okay, so this is all about your myocardial action potential, which is very simple. We already discussed the just a brief review what we discussed. Okay, now we're going to discuss the nodal action potential. So nodal action potential is little bit different. Why? Because they can generate their own current. So their nodal action potential is actually different. Now in the SA node and the AV node, what happens to them? Their resting membrane potential is less negative. They have the less negative resting membrane potential. Why? Because they can generate their own current. So this will be my graph for them. And in this graph, this is my minus 80. This will be my minus 60. This will be my minus 40. And this will be my minus 20. And this will be my, I would say, 0 being there. And this is plus 10. So they are resting at minus 60 or around minus 60 or minus 65. So this is their resting membrane potential. They are resting. Now they are resting here. So what happened to them? They will actually go to minus 40. Minus 40 is a threshold point for them. So minus 40 is a threshold. So they go from minus 60 to minus 40. This is called phase 4. And phase 4 is responsible for the automaticity of their current generation. So because of this phase 4, they can generate their own current. Now look at this. In the phase 4, I'm going from minus 60, I'm going to minus 40. So it means I'm getting less negative. It means some positive ions are going into the cell. Okay, some positive ions are going into the cell. So what positive ion go into the cell? They will be called your sodium current. So that will be called funny sodium current, because normally we don't see the sodium going into the cell without any stimulus. So they are called what? Funny sodium current, which is due to the funny sodium channels. Why they are called funny? Because they are the atypical sodium channels. Atypical sodium channels. Okay, atypical sodium channels. So it's called the funny sodium current. So it is actually different from the other sodium channels, which are actually responsible for phase 0 of the myocardial action potential. Okay, so once they reach to the minus 40, they can generate their own current. Then they will get depolarized. So when they reach to minus 40 here, at minus 40, the calcium channels will open, which are responsible for the phase 0 of the nodal action potential. So this will be my phase 0 of nodal action potential, where they go from minus 40 to plus 10. And this is due to your calcium channels opening, phase 0. Phase 0 is due to the calcium channels being open. So can anybody tell me why at the minus 40, the sodium channels are not open? What's the reason? Why it is due to the calcium going in? So that's because of the opening of the calcium channels.
They need more negative potential.
Excellent, very good, Rao. So for the sodium channel to be open, they need a more negative resting membrane potential. They will never be open at minus 60 or minus 40. Okay, So this is called phase 0, and after phase 0, they will have the phase 3, which is due to the opening of the potassium channels. So potassium will go out, so potential will return back to its minus 60. This is called, green phase is called your phase 3. This is called repolarization phase. Repolarization. Okay, this is called repolarization phase being there. All right, so that is how the nodal action potential being there. Now, if you want to change the heart rate, you will affect always phase 4. So there are certain situations which will decrease the slope of phase 4, and there are certain parameters which will increase the slope of phase 4. Suppose what parameters will actually increase the slope of phase 4? Normally I take 4 seconds. I take 4 seconds to go from minus 60 to minus 40. So at 4 seconds, my heart rate is actually 70. Okay. Now, what are the conditions which will actually cause me to take a more time to go from minus 60 to minus 40? That will be like this. So I increase the slope of the phase 4. So here I take how much seconds? I take 8 seconds. I took how many seconds? I took 8 seconds to go from the minus 60 to minus 40. So my heart rate is going to drop to the 50. That will be seen when I have the more parasympathetic stimulation, because parasympathetics will slow down my heart rate. Or it will be only possible when I'm taking the beta blockers. Beta blockers or calcium channel blockers, which will slow down my SA node and AV node. Okay. Now, what if I decrease the slope of phase 0? So I decrease the phase of slope, or this will be like this. So I take less time to go to the minus 60. I took only 2 seconds. It is only possible when I have the increased sympathetic stimulation to the heart, which is being seen in the beta agonist drugs. Okay, beta agonist drugs will actually increase my heart rate. Okay, so that's all about your nodal action potential being there. Now we're going to jump to the ECG. So ECG, in the ECG, what is going to, in the ECG, ECG is electrical recording of the left side of the heart. So first wave which is produced in the ECG, that will be called P wave. Now P wave indicates what? It indicates your atrial depolarization. So after atrial depolarization, what is going to happen? The current will go to the AV node, and after AV node, the current will go to where? It will go to your left ventricle. So left ventricular depolarization is going to produce what? QRS complex. So you get QRS complex will be seen. So this will be my QRS complex being seen. Okay, this will be my Q wave. This will be my R wave. This will be my S wave. Okay, so QRS complex is going to be produced. And now after this indicates your ventricular depolarization. And then you will get what? T wave being there. So this will be my T wave, which indicates my ventricular repolarization. So T wave indicates ventricular repolarization. QRS is ventricular depolarization. Okay, and the P wave is all about your atrial depolarization. Now in the ECG, you have what? You have the intervals being there, and you have the segments being there. Okay, so you have the 3 intervals and the 2 segments. So first we discuss the interval. So we have the one interval that's called PR interval. So this will be your PR interval, which is start from the beginning of the P wave till the beginning of your Q wave. That will be called PR interval. PR interval. Okay. Okay. And after PR interval, we have the QRS interval, which is from the beginning of the Q wave till the end of the S wave. That will be called QRS interval. QRS interval indicates what? It indicates the ventricular depolarization. Okay. And the last interval will be called QT interval, which is from the beginning of the Q wave till the end of the T wave. And this QT interval indicates what? It indicates the ventricular depolarization, ventricular contraction, and your ventricular repolarization. Okay. So that will be your QT interval for you. All right. Now we have another 2 segments being there. Segment, we have the PR segment, which start from the end of the P wave till the starting of the Q wave. That will be called your PR segment. So PR segment indicates what? Can anybody tell me what does a PR segment indicates?
AV nodal delay time.
Yes, PR segment is going to indicate the AV nodal delay. AV nodal delay will be seen. So AV nodal delay is going to be PR segment being there. Okay. So any disease which increase the AV nodal delay, that's going to show us what PR interval being prolonged. Okay. Or PR segment is going to be prolonged. Now other is called ST segment. ST segment actually start from the end of the P wave, end of the S wave till the beginning of the T wave. That will be called ST segment. This will be my ST segment being there. And the importance of ST segment is what? ST segment is normally an isoelectric line being there. So if you get ST elevation, it indicates MI. And if you get ST depression, it also indicates your MI being there. All right. So this is very simple explanation of the EKG. Now we jump into the ANP and the BNP being there. So ANP is actually coming from where? It is actually coming from the atria. Okay, source is atria. And what is the stimulus for the release of the ANP from the heart? That will be your increased volume of the blood in the atria. Blood. When you get the increased volume of the blood in the atria, that will be, so it will lead to release the ANP. Okay. So function of ANP is what? Is to remove the water out of the body. Water out of the body. So how ANP is going to remove the water out of the body? In the kidney, it is going to do what? In the kidney, it will cause the vasodilation of efferent arterioles by increasing cyclic GMP. So cyclic GMP will lead to what? Increased renal blood flow. And when you increase the renal blood flow, what is going to happen when you increase the renal blood flow?
GFR is increased.
GFR increases, and that will increase the sodium excretion. Okay. And when the tubules, it will do what? It will decrease the sodium reabsorption. Okay. So it's a protective mechanism. Simply, it's a protective mechanism which will allow the sodium to be excreted. Okay. So you get nitriuresis, and it's being responsible for the aldosterone escape mechanism as well. Now, other is called BNP. BNP is actually coming from the ventricles, and the function of BNP is same. Function of BNP is same, leads to nitriuresis. But how it is different from ANP? BNP is having the longer half-life. Longer half-life. Okay. So that's all about ANP and the BNP. Now we jump into the baroreceptors being there. Baroreceptors. So baroreceptors are what? Baroreceptors are the receptor which senses the pressure changes in the large blood vessels. So baroreceptors should be located in the large blood vessels. So their location is what? They are located in the aortic arch. Aortic arch. Aortic arch. So they will actually sense the pressure changes. So whenever your pressure increases in the aortic arch, whenever blood pressure increases, it will lead to increased stretching of the aortic valve. So it will lead to what? Increased firing rate of the baroreceptor. Increased firing. So there will be increased efferent going where? These efferents will go where? Increased efferent fibers will go to medulla oblongata. They will inform the medulla oblongata the pressure is very high in the periphery. Please reduce the pressure. So how medulla oblongata is going to reduce the pressure? Medulla oblongata will increase the parasympathetic stimulation to heart. So when you increase the parasympathetic stimulation to the heart, these will be the efferent fibers, and these efferent fibers are also your vagal fibers. Okay. So vagus nerve is actually carrying the efferent fibers from the aortic arch, and efferent fibers are also parasympathetic. So that will be also vagus. So they will increase the stimulation to the heart, which will decrease the heart rate and increase the AV nodal delay time. AV nodal delay. Okay, so this is how you reduce the blood pressure when your pressure increases. Similarly, these baroreceptors are also present in the carotid.
Sinus.
Yeah, carotid sinus. So here, the efferent fibers from carotid sinus are glossopharyngeal nerve. Okay, glossopharyngeal nerve is there, which is called the cranial nerve 9. Cranial nerve 9 is going to carry these signals to your medulla oblongata, and then medulla oblongata will actually sends the parasympathetics to your heart to reduce the blood pressure. So this is a response to the high blood pressure. Now, baroreceptors are also the components of the Cushing reflexes. So what happens in Cushing reflex? The Cushing reflex is actually seen in the patients who have the high intracranial pressure. So when you get high intracranial pressure, what will happen to the blood flow to the brain?
Decreases.
Very good. So increased intracranial pressure will decrease blood flow to the brain. Okay. And when you decrease the blood flow to the brain, what will happen? The brain will do what? Brain will increase the sympathetic stimulation, because brain will do what? It will try to increase the sympathetic stimulation to cause the vasoconstriction of cerebral blood vessels, because vasoconstriction will increase the pressure in the cerebral arteries. So there will be increased sympathetic stimulation. So when you increase the sympathetic stimulation, it means you get vasoconstriction. And when you cause vasoconstriction, what will happen to the peripheral blood pressure?
Increases.
Peripheral blood pressure is going to be increased. And this pressure will be sensed by the baroreceptors in the aorta. So they will have the more firing rate. Vagal firing rate will increase. And when vagal firing rate increases to the medulla, medulla will do what? It will decrease the heart rate. So that is the second component. So you get bradycardia, heart rate being decreased. So first you get hypertension, then you get bradycardia. Now third component of Cushing reflex is called your respiratory depression. Can anybody tell me what is the reason of the respiratory depression of the Cushing reflex?
Because respiratory
Carbon
center
dioxide will be
in the medulla.
Because of the herniation of the
Herniation of medulla oblongata.
respiratory center is affected the medulla oblongata. So Cushing reflex is composed of the high blood pressure, and it is composed of what? It's actually composed of your decreased heart rate, second component, and the third component of the Cushing reflex will be respiratory depression. Okay, so this will be the Cushing reflex. It's being discussed here because it's a component of the baroreceptor mechanism. Okay, so now other is called your chemoreceptor, which are very so chemoreceptor senses the changes in the blood chemistry. Chemoreceptors. So any change in the blood chemistry, like that senses the change in the blood carbon dioxide level, PaCO2, your blood pH, and your PaO2. So we have the two types of chemoreceptor. One is called peripheral chemoreceptor and it's called central chemoreceptor. So peripheral chemoreceptors are located in the aorta and the carotid sinus. Okay. So peripheral chemoreceptors are actually called carotid and the aortic bodies, which are being stimulated by increased carbon dioxide, decreased pH of the blood, and decreased PO2. That is your oxygen level, and the oxygen will be less than 60. Less than 60, then they will be stimulated. Okay. So these are the peripheral receptors being there. So whenever your carbon dioxide level, so how does they work? They work in the similar mechanism like your baroreceptor. So whenever your carbon dioxide level goes up, what will they do? They will stimulate the respiratory center in the medulla oblongata through the vagus nerve. So medulla oblongata will increase the contraction of diaphragm, will cause the hyperventilation being there. So similarly, we have the central chemoreceptors being there. Central chemoreceptors. Okay. So central chemoreceptors are actually what? Central chemoreceptors are actually stimulated by your carbon dioxide level.
Carbon dioxide only.
And the pH of the blood, but they are not responsive to the oxygen level. Okay. They are not responsive to the oxygen level. Okay. So COPD patients, the patient who have the COPD, they have the chronically elevated carbon dioxide level. All the time their carbon dioxide level is high. So which will lead to the down regulation of the chemoreceptor in the central nervous system. So the respiratory rate or ventilation of COPD patients is dependent on the peripheral chemoreceptors. And the peripheral chemoreceptors are very sensitive to your, in case of COPD patient, they are responsive to the oxygen level. oxygen level. So that is the reason in the COPD patient, we always give the decreased amount of oxygen from the required amount. So if the COPD patient requirement of oxygen is 4 liter, we always keep them on the 2.5 liter or 3 liters of oxygen because we want peripheral chemoreceptor to be active. Okay, so if I give the 4 liters of the oxygen to the COPD patient, the peripheral chemoreceptor will not sense any changes. So patient might get the accumulation of carbon dioxide and they may die. Okay, so that's all about your baroreceptor and the chemoreceptors. Now we are going to discuss. Okay, so what is your question, Asif? There's a lot of the chats being there. So whenever there's activation of barochemo, both will initiate parasympathetic response. Now, not a parasympathetic, not parasympathetic. You know what happens whenever your chemoreceptors are activated? Vagus nerve. You can say whenever baroreceptor, chemoreceptor are activated, their efferent fibers are same, but efferent fibers are different. You know, how can you increase the respiratory rate with the increase in the parasympathetics? Okay, so in order to increase the respiratory rate, you need the diaphragmatic contraction, and the only way to cause the diaphragmatic contraction is to stimulate the phrenic nerve. Okay, now we're going to discuss your no problem. Okay, we're going to discuss capillary fluid exchange. Fluid exchange. So what is capillary fluid exchange means? The exchange of the fluid happening at the level of the capillaries, or simply I would say the movement of the blood or movement of the filtered from the capillaries into the tissue space is called capillary fluid exchange. So there are some forces which favor the capillary fluid exchange and there are some forces which actually oppose it. So can anybody tell me what are the two forces which will favor the filtration at the level of capillaries?
One is hydrostatic pressure, other is oncotic pressure.
Oncotic pressure.
Oncotic pressure where?
Interstitium. Hydrostatic pressure at the interstitium.
Very good. So very good. So one is called hydrostatic pressure of the capillaries. Hydrostatic pressure of the capillaries that will favor the filtration. And second will be called oncotic pressure in your interstitial fluid. Oncotic pressure of interstitial fluid. Okay. So if these two pressures are increased, it will lead to more filtration to happen. And if you get more filtration, it means you are going to get accumulation of fluid in the interstitial space. That is called edema. Okay. So two forces are there. And what are the two forces which oppose the filtration? That will be the oncotic pressure within your capillaries. So when you have the increased oncotic pressure, which is dependent on the albumin concentration, oncotic pressure in your capillaries, and second force which will oppose the filtration will be called your hydrostatic pressure within the interstitium. Because if you have the more pressure in the interstitium, it will do what? It will stop the blood from coming out into the interstitial space. So these forces should be very important to understand because now I'm going to discuss a disease. So what are the diseases in which my hydrostatic pressure in the capillaries will increase? Increase hydrostatic pressure of capillaries, which will lead to the edema. Is it?
Heart failure.
Very good. Heart failure. Very good. Heart failure because of the backward movement of the blood. So blood is going to stay. So in the heart failure, you always get what? You get the edema, is it? You get the edema in case of the heart failure. Very good. So what are the diseases in which your oncotic pressure in the interstitial space will increase, which will lead to the edema?
Nephrotic syndrome.
Nephrotic syndrome.
The oncotic pressure increases in the interstitial space.
Lymphedema.
Lymphatic blockage.
Lymphedema, very good. Lymphedema, excellent. And that edema is going to be what? Non-pitting or pitting edema?
Non-pitting.
Non-pitting. It will be very difficult to produce a pit because fibrous depositions are there in the interstitial space. Very good. So lymphedema is there. Now, what are the diseases in which the oncotic pressure decreases in the capillaries, which will lead to the edema?
Nephrotic syndrome. Hypoalbuminemia.
Nephrotic syndrome is the one. Very good. What other disease?
Liver cirrhosis.
Liver cirrhosis.
Malnutrition, cirrhosis.
Malnutrition, very good. What malnutrition? Kwashiorkor or marasmus?
Kwashiorkor.
Kwashiorkor.
Very good. Protein malnutrition, very good. Okay, protein malnutrition. Now, you can get edema even when you get change in the capillary permeability. When the capillary permeability is changed, so what are the diseases in which the permeability of capillaries are changed?
Sepsis, malignancy,
burns, snake venom.
Burn and toxin.
Infection. Infection, very good. You know, when you get bacterial infection, you get edema, you get the pus. Very good. And could be the toxins. Very good. Like carbon dioxide, carbon monoxide toxins, they are going to change your capillary permeability. Okay.
even malignancy.
Malignancy can be there. Yeah, you're right. Okay. So we're going to start the pathology. Okay. You guys want to do the pathology today? I think you guys are good in the pathology. Is there any need to do it?
Yeah,
Yes.
we need it. You are telling very nicely.
You need it?
Yeah.
So you guys are feeling tired? Not tired? You're good?
Yeah, we are good.
Yeah. So we take a 2-minute break. How long is this? I don't know. To be honest, I don't know. Okay. I don't know how long it's going to end. Okay. Okay. So, okay, we will be actually
Sir,
quick.
we have pharmacology, cardiac pharmacology lab.
Oh, really? Oh, really?
Yeah.
So you guys want to do a pharma now or pathology?
Pathology followed by pharma.
Pathology followed by pharma?
No.
I think you guys.
We already have pathology recording, but we didn't have
So this is a good.
pharma class yet.
So let's do a pharma and complete it and wrap up our class. Is it?
Yes, sir.
Okay. So you guys want to leave?
Pharma.
So there's no need to do the pathology.
I
Okay?
think since we already
No,
did
please,
pathology,
pathology
we
also.
can just look back in the to the lectures that you've already uploaded. We
Exactly.
can go through them again.
Yeah.
And since we didn't do pharmacology, I think we should be, more awake for pharmacology. Because if we did pathology and then did pharmacology, I think we won't get pharmacology then
Yeah.
because it'll get too late.
Then we can do pharmacology followed by pathology.
No. We do.
We already did pharmacology and the lectures have been uploaded.
We will do only one thing. Either pathology or pharmacology. So
Yeah,
now
pharmacology wasn't completed, so I
Pharmacology.
think maybe we should do pharmacology.
Yes, sir. Pharmacology is better.
because we can do only one thing, pharmacology or pathology.
Pharmacology, because we didn't do it.
Pharmacology.
Pharmacology. So no boot camp for the pathology, okay? Okay. Pharmacology.
Can you share the recordings for pathology, please?
I shared already. I already shared. I already shared with you guys.
Maybe she is not part of the paid
Yeah,
program.
I'm not the part of the paid program.
So you should pay. Okay? You should pay. We are working hard for you guys. You should pay at least.
Yeah, it's really worth it. Thank you so much. I will start paying.
You start paying. Okay.
Yeah, it is my first time. It was wonderful. Thank you so much.
Thank you. Thank you so much. We get some benefits. So I'm getting some motivation. Any other
Yeah,
student?
you are teaching very well.
Any other student who wants to join? So I will get more motivation. Is it?
I will join later because I'm traveling right now. So
Ah.
out of the events. So as soon as I enter the US, I will join that time. Maybe October, second week of October.
Okay, I see. Okay. Yep. Okay. So you want to do the pharmacology, is it?
Yes, sir.
Okay. Okay, so we just take a 2-minute break and then we start the pharmacology, okay? Right away. Okay.
والله ما وقت خبر نفسه من ذاك الجاينت مش
All right, so I'm back. Okay, so let's do the pharmacology first. Okay. So in the pharmacology, first we will discuss first blood pressure, treatment of the blood pressure. How do we actually treat the blood pressure? So you guys know that blood pressure is equals to what? Blood pressure is equals to your cardiac output and times total peripheral resistance. So you can treat the blood pressure by decreasing the cardiac output or decreasing the total peripheral resistance. So this is called essential hypertension. You guys know essential hypertension was actually equals to these two parameters. So how can I decrease my cardiac output? What are the medications which can decrease my cardiac output? It will be, okay, it will be, so medication which will decrease the cardiac output will be what? They will diuretic, very good, because cardiac output is equals to heart rate times stroke volume, is it? So very good. So could be the diuretics, very good. What other medications will decrease my beta blocker? Excellent. So these two medications are can be used to treat your essential hypertension. Okay, diuretics and your beta blockers. Okay, and other way is to decrease the total peripheral resistance. So TPR can be reduced by the ACE inhibitors or your angiotensin receptor blocker and the calcium channel blocker. So two medications to reduce the TPR, two medications to decrease the cardiac output. They can be used to treat the hypertension. That's called essential hypertension. Okay. Now, how will you treat the hypertension in the heart failure patients? So first you have to understand what is the cause of hypertension in the heart failure patient. The cause of hypertension in the heart failure patient is the increased activity of the RAS. Is it? Which is secondary to the decreased renal blood flow. Okay. So we have to use the drugs which target my RAS system. So what are the drugs which are going to target the RAS? Will be obviously ACE inhibitors and the ARBs.
ACE and ARBs.
And the ARBs will be there. Or what is the other drug which will target the RAS? Yep, that will actually decrease my blood pressure. Yes. So I can use
Aspirin?
Very good. Spironolactone, excellent. Spironolactone. So these medications are being used to treat the heart hypertension in the heart failure patients. Okay. Or you can use I would say the beta blockers can be used because they're going to slow down your heart. Okay. Diuretics can be used because stasis of the blood is actually there in the heart failure patients. Okay. All right. So, the best medication which we use for the heart failure patient and the hypertension is a combination of your ARBs, angiotensin receptor blockers, with sacubitril. Okay, sacubitril is always combined with this sacubitril, which is called neprilysin inhibitor. Sacubitril will do what? It will actually increase ANP, which will reduce the preload in the heart, and ARBs will decrease the afterload, so your hypertension can be treated in this way. Now, how do you treat the hypertension of the diabetic patient? Diabetes mellitus. Patient is having diabetes. What is the best medication to treat hypertension? ACE inhibitors or ARBs should be the first line.
ARBs.
Yes, you can use the beta blockers as well. Beta blockers can be used.
They mask the hypertension, but
Yeah, I'm going to come to that point. So beta blockers should be used with a cushion because they might mask the symptoms of hypoglycemia. Masking the symptoms of hypoglycemia means they will actually reduce hypoglycemia will cause palpitation in the patient, which gives the awareness to the patient to go and eat something, So if they are on the beta blocker, they will not get aware that they have the hypoglycemia. Okay, so it should be used in the questionly. Now, hypertension in the asthma patients. How do you treat the hypertension in the asthma patients?
we should not give non-selective beta blockers.
Yep, very good. There should be no use of the non-selective one because they will actually worse the symptoms. Very good. And there should be the use of angiotensin converting enzyme inhibitor, ACE inhibitors. Yes, ACE inhibitors should be avoided here. And why the ACE inhibitors should be avoided? Because ACE inhibitors,
Bradykinin.
yes, they are going to cause exactly. Okay, so yes, exactly. So they are going to cause what? They're going to increase the bradykinin. And when you increase the bradykinin, what is going to happen? You are going to get the cough. Is it? So they will increase your cough being there. So that's why we don't use ACE inhibitors and the non-selective beta blocker in these patients. Now, how do we treat the hypertension in the pregnancy? So pregnancy-induced hypertension can be treated with the
Methyl dope.
methyl dopa. We don't use, no longer we use methyl dopa nowadays because of toxicity. So methyl dopa is not preferred here. So we use calcium
Labetalol,
bean when we use them.
hydroxyzine.
So they are the separate things to use. So now we will be discussing the hypertensive drugs in the details. So first group we are going to discuss is called calcium channel blockers, CCBs. So calcium channel blockers are
Nifedipine.
classified. Let me clear first, please. Okay, when I say tell me, then answer, please. Okay. All right. So calcium channel blockers are classified into two groups depending on the side of the action. Depending on the side of the action, so the calcium channel blockers which act on the vascular smooth muscle cells, they are called dihydropyridines. Dihydropyridines. So they are called dipines or dihydropyridines. Dihydropyridine calcium channel blockers. So in this group, the drugs which comes here, that will be called your dipines. That will be your, I would say, amlodipine, clevidipine, nifedipine. So amlodipine, these are the drugs. So their suffix is what? Their suffix is going to be dipine. Amlodipine. Okay. Amlodipine being there. Okay, that will be called your calcium channel blockers, which act on the blood vessels. So that is the mechanism of dihydropyridines. Now, what are the clinical uses of these dihydropyridines? These are being used to treat what diseases? Because they are actually blocking the calcium channels on the blood vessels. So we can use these drugs to treat the hypertension. They are the selective for your vascular smooth muscles, and they can be used to treat the angina. And how do they treat the angina? How does they help in the angina? Because they are going to reduce the afterload. If they reduce the afterload, the myocardial oxygen demand will be decreased. Okay, so they can be used to treat the vasospastic angina because they are the first line for that, because they cause what? Vasodilation of the blood vessels. Okay, now these can be used to treat the Raynaud phenomena as well. Can anybody tell me what is Raynaud phenomena?
Vasospastic.
Yes, I would.
Peripheral blood.
So Raynaud phenomena is what? Raynaud phenomena is actually the hyperactivity of vascular smooth muscle cells of the blood vessels
Due to cold.
due to due to cold. Cold is a trigger. So cold and smoking is a trigger. Smoking in the cold is a trigger, which will. So vascular smooth muscle cells are very irritable. They need just a trigger to contract. Okay. So when they contract, they will reduce the blood flow to the skin. So you get the blue toe or blue fingers being there. Okay. So in order to reduce the spasm of these blood vessels, we will do the calcium. We will use the calcium channel blockers. Okay. So that's why calcium channel blockers are very good. They can be used to treat Raynaud phenomena. Now, there are specific calcium channel blocker which can be used to treat the subarachnoid hemorrhage. So, what calcium channel blockers we use in the subarachnoid hemorrhage? Can anybody tell me?
Nimodipine.
Do you know why? Why do we use nimodipine? Why not other calcium channel blocker?
Vasospasm.
Yeah, you're right. It prevents the vasospasm. That's my next question from you guys. But here, why nimodipine is used? Only nimodipine. Why not amlodipine? Because nimodipine is the only calcium channel blocker which can cross blood-brain barrier. Okay. And what is the role of nimodipine? How does it actually treats the subarachnoid hemorrhage? It prevents cerebral vasospasm. And can anybody tell me what is the pathophysiology here? Why do I get the cerebral vasospasm in subarachnoid hemorrhage?
Irritation by the blood.
Excellent, very good. So in subarachnoid hemorrhage, you get the within the subarachnoid space, and that subarachnoid space is very close to the cerebral blood vessels. So when the blood strikes with the cerebral blood vessels, it will lead to cerebral vasospasm, and that cerebral vasospasm will decrease blood flow to the cerebrum. Is it? So decreased blood flow to the cerebrum will lead to what? Ischemic stroke. You will get ischemic stroke. So in order to prevent the ischemic stroke in the subarachnoid hemorrhage, we will use the calcium channel blocker that is called nimodipine. Okay, nimodipine is actually used to prevent subarachnoid hemorrhage. Okay, or prevent the cerebral vasospasm in the subarachnoid hemorrhage. Okay, Now, what are the calcium channel blockers which are being used to treat the hypertensive emergency and the urgency? Hypertensive emergency and the urgency, these will be the calcium channel blocker that will be called clevidapine. Clevidapine. You know, guys, hypertensive emergency and the urgency, you get the high blood pressure, which can cause the end organ damage, which is called emergency. So clevidapine can be there and nicardipine is there. Why? Can anybody tell me why? Why do we use these calcium channel blockers to treat hypertensive urgency and emergency? Why not amlodipine? Because these are the two calcium channel acting, which are the rapid acting one, and they have the rapid onset of the action. So in the urgency, I want a rapid onset to be there. So these are the clinical uses of your dihydropyridine calcium channel blocker. Now their side effects are very simple to understand. Side effects. Yep.
Headache,
They can give
flushing.
very good. And these side effects are due to the vasodilation. So side effects, keep it very simple. They are due to vasodilation. So headache can happen due to the vasodilation. Flushing can happen. Very good.
Edema.
Can be there. Excellent.
Peripheral edema.
Very good.
Amyloid.
Edema can be there and dizziness can be there as well. Okay.
Gingival hyperplasia.
Very good. Gingival hyperplasia. Could you please tell me the mechanism? How does they cause gingival hyperplasia?
Fibroblastic growth factor.
Very good. They will actually activate the fibroblast growth factors. They will activate the gingival fibroblast. So fibroblast will actually lead to fibrosis of the gums. Could you please tell me what are two other medication which can cause gingival hyperplasia?
Phenytoin also causes.
Very good.
Cyclosporin.
Cyclosporin, excellent, very good. Cyclosporin, very good. So these are the medications which can cause gingival hyperplasia. So that was all about your dihydropyridine group. Now we discuss the non-dihydropyridines. And non-dihydropyridines, they are actually cardioselective. Simply, they are what? Cardioselective, non-dihydropyridines. Non-dihydropyridines. So these are only two drugs are in this group, which are actually called your verapamil and deltaism, which blocks the calcium channels within the heart. Verapamil plus deltaism. So their mechanism of action is what? They blocks the calcium channels within the heart. So what will be the clinical use of them if they are blocking the calcium channels on the heart? Yes.
Decreases the contraction.
The contraction, very good.
Because calcium cannot enter, so there is no contractility.
So contractility will be reduced, plus they are going to increase the AV nodal delay.
Yeah.
We increase the AV nodal delay in the atrial flutter and the fibrillation patients. We have to control the rate, okay? So these are the drugs which are being used to treat atrial fibrillation and the flutter. Hypertension can be there because they reduce the contraction and angina as well. So what are the side effects of these two drugs? Side effects of these two drugs? Because they will slow down your heart, so you might get a bradycardia. They can
Constipation.
give you the AV blocks. They can give you the AV blocks, and they can also give you the constipation. Very good. That's a common complaint we get. And can anybody tell me what's the mechanism of constipation here? How does they cause a constipation? So they will cause the constipation by slowing down the pacemaker cells of the. So inside the gut, we also have the pacemaker cells. They are called interstitial cells of Kegel. So they have the tendency to slow down the pacemaker cells of the heart, pacemaker cells of the gut as well. So you get what interstitial cells of Kegels are going to be. Okay, interstitial cells of the Kegel will be slowed down. Now, other side effect of this drug is that it can cause increased prolactin. Cause prolactin being high. Can anybody tell me what's the mechanism? How does it increase the prolactin?
Decrease the dopamine release.
Dopamine.
It is going to decrease the dopamine release from the hypothalamus, so your prolactin will be increased. So you will get what galactoria can be there, amenorrhea can be there, or decreased libido will be there. Okay. So you guys were saying gynecomastia. Prolactin doesn't give you the gynecomastia. Okay. All right. So that will be your calcium channel blocker groups. Now we will discuss the another antihypertensive, which is called hydralazine. Every antihypertensive will be what? Vasodilator. Hydralazine. Hydralazine will be there. So hydralazine mechanism of action is what? It's going to act on the blood vessels. So within the blood vessels, the hydralazine is going to increase your cyclic GMP. Okay. So when you increase the cyclic GMP will actually leads to what? It will lead to relaxation of vascular smooth muscle cells. And how does it cause relaxation of vascular smooth muscle cells? Can anybody tell me the mechanism?
Nitric oxide formation.
Nitric oxide formation will increase cyclic GMP. So when you increase the cyclic GMP, it will lead to increased activity of myosin, light chain, phosphatase, which is going to remove the phosphate from the myosin. And when you remove the phosphate from the myosin, what is going to happen when you remove the phosphate from myosin? The muscle will get relaxed. So actin and the myosin filaments will detach from each other. So you get what? Relaxation of your vascular smooth muscle cells. Okay. So this is how your myosin light chain kinase phosphatase work. Okay. So hydralazine has a more effect on the arteries. It's a more arteriodilator compared to the venodilator. Okay, it's an arteriodilator. All right. So if it's an arteriodilator, what will be the clinical uses of the hydralazine? Hydralazine can be used to treat what diseases? Hydralazine is actually used to treat severe hypertension, especially your hypertension emergency. We can treat with hydralazine severe hypertension. Severe hypertension. Okay. Severe hypertension, particularly acute one, and it can be used to treat the heart failure because in heart failure we get the hypertension. So with the organic nitrates, we can use hydralazine to treat the heart failure. Okay. So hydralazine also is used to treat the hypertension during pregnancy. I told you guys, but you know what will be the side effects of hydralazine? Side effects of hydralazine because of vasodilation, it might cause a reflex tachycardia. Is it? You might get what reflex tachycardia. And that reflex tachycardia is very severe. So in order to reduce the risk of reflex tachycardia, we always use hydralazine with a beta blocker. We always use hydralazine with a beta blocker to actually prevent the reflex tachycardia. Okay. So because of this reflex tachycardia, hydralazine is always contraindicated in the angina patients. So patients with angina or coronary artery disease, do not use hydralazine in these patients. If you use the hydralazine, that might lead to what? Increased oxygen demand. So patient might die from the MI or heart attack. Okay. So what is the other use of the hydralazine? Hydralazine side effects could be what? It can lead to what? Edema can be there because of vasodilation. You get edema. You get what? Headache. Now hydralazine can also cause one side effect that's called drug-induced lupus. You might get the lupus with the hydralazine. Lupus with the hydralazine will be there. Okay. And that lupus is actually there. Lupus. So can anybody tell me what are the other two drugs which can cause drug-induced lupus?
Isoniazid and then
Procainamide.
Procanamida.
Minoxidil.
Ethambutol.
Is there very good. What else?
INH.
Isoniazid.
Isoniazid. Very good.
Isoniazid.
Very good. So these are the side effects of hydralazine. Now we jump into the other drugs which are called your nitropuracide. So nitropuracide is also your vasodilator. And why it is vasodilator? Because nitropuracide is going to increase the nitric oxide release. Okay, nitric means what? Increases nitric oxide. So if you increase the nitric oxide, what happen? Nitropuracide. It will increase what? It's going to increase the nitric oxide. Is it? And if it increases nitric oxide, it's going to increase the cyclic GMP. Okay, so they both increase cyclic GMP. What is the difference between nitropuracide and the hydralazine? Nitropuracide is actually going to have the equal effect on the arteries and the veins. It's an equal effect. So it's a good drug, means it has actually 50% effect on the arteries and the veins being there. Okay, so what is the clinical use of the nitropuracide? Nitropuracide is being used to treat hypertensive emergency and the urgency. It's being not angina. Angina is for the nitrates. That is a different group. Okay. So it's being used to treat the hypertensive emergency and the urgency because a rapid acting drug. So we can use this drug. What is the side effect of nitropuricide?
Cyanide poisoning.
It can cause a cyanide toxicity. Okay, so that's all about your nitropuricide being there. Now, other drug which we are going to discuss will be called your nitrates. Nitrates are different from the nitroglycerin. Nitrates are there. So what does the nitrates do? Nitrates are going to do what? Nitrates includes what? Nitroglycerin. So in this group, what drugs are there? Nitroglycerin is there, isosorbide dinitrate is there, and isosorbide mononitrate is there. Which are the drugs? These are the drugs. So what's the mechanism of them? So these are what? These are going to do what? They're going to increase the nitric oxide level in the vascular.
Vein.
Yes, very good. So increase nitric oxide in the veins. So they are what? Simply they are the venodilators. More effect in the veins compared to the arteries. They are venodilator. So their mechanism, their effect is opposite to your hydrolysine in terms of the location. Okay, mechanism wise they are same. So they are going to increase the cyclic GMP within the. So every vasodilator is going to do what? Increase cyclic GMP in the vascular smooth muscle cell. So when they do what? Venodilation, they are going to decrease the preload to the heart. Decrease preload to the heart. Okay. Okay, so you decrease the preload to the heart. Now, what is the clinical uses of these drugs? In what disease you want to decrease the preload to the heart?
Angina.
Angina.
Angina is there. Very good. Angina.
Heart failure.
Why angina? Because if I decrease the preload in the angina, the myocardial oxygen demand will be obviously decreased. Yep. And
Yes.
disease which I use here is will be called pulmonary edema. Can anybody tell how it improves the symptoms of the pulmonary edema?
They decrease the preload.
Very good, Archana. Excellent. Very good. So what will happen? It will decrease the right ventricular blood flow, decrease right ventricular blood. And when you decrease the right ventricular blood, you will decrease the blood in the lungs, which is actually required in the pulmonary edema. In the pulmonary edema, you already have the more blood in the lungs. So your goal as a physician is to reduce the blood in the lungs. The only way to reduce the blood in the lungs is to do what? Is to decrease the blood in the right ventricles, then decreased blood will go to the lungs. Okay, so side effects of the nitrates are
Headache.
you get what? You are going to your headache, very good, because of vasodilation, you get the headache.
Hypotension.
Hypotension will be there, excellent, because of vasodilation. Every side effect is again due to the vasodilation, very good. What else you are going to get? You are going to get what else? You are going to get the flushing because of the vasodilation, more blood will go to the skin. So you get flushing being there. And lastly, you are going to get what? Tachycardia, reflex tachycardia will be there. Palpitation is going to be seen with these men. Now, last side effect which we see in the nitrates is called, it can cause methemoglobinemia. Methemoglobinemia means what? It will convert your iron from Fe2 to Fe3 state. Okay, so iron will go from Fe2 to Fe3 state.
Ferrous to ferric.
Yeah. So Fe2, so this will get oxidized. It will get oxidized. That's called methemoglobinemia. Now we see the Monday disease with the nitrates. Monday disease is very easy to understand, which is because it is seen in every one of us get the Monday disease. So this Monday disease is due to the tolerance to the nitrate side effect. And it's very commonly seen in the industrial workers who are exposed to the nitrates every day. So from Monday to Friday, they are continuously exposed to the nitrates. So when they are continuously exposed to the nitrates, they will develop the tolerance to the side effects of the nitrates. And tolerance means what? You get gradual decrease in the side effects produced by the nitrates. So that tolerance is being developing from Monday to Friday. Okay. So now what happens? This tolerance is due to what? Is due to down regulation of the receptors of the nitrates. You get down regulation of the receptor. Number of receptors get decreased. So down regulation of the receptor. Because of chronic stimulation, you get receptor down regulation. So At Friday they will not have any symptom from the nitrates because there are no receptors being available. But weekends they are not exposed to the nitrates.
Mama is coming. Mama is coming. Come on.
Saturday and during Sunday.
Um,
During Saturday and during Sunday, what happens? They are not exposed to the nitrates, so it leads to upregulation of nitrate. Upregulation. Upregulation of the receptors there, receptor. And when they come back on Monday, on the Monday, what will happen? They are going to get the symptoms that is called headache, flushing, palpitation because of the upregulation of the receptors. So this is called the Monday disease, which is commonly seen in the nitrates workers. Okay. All right. Now, there are certain conditions or certain disease in which nitrates should be contraindicated. They are contraindicated. So nitrates are contraindicated. In what situation the nitrates are contraindicated? Yeah.
right ventricular infarction.
Right ventricular infarction. Very good. Why?
Because nitroglycerin decreases the preload.
Well, so
In
it,
right.
yes, it is going to further decrease the right ventricular volume, and you're going to decrease further contraction of the right ventricle. Okay. So if you decrease preload, you're going to decrease the right ventricular contraction. So which you don't want in case of right ventricular infarction. Very good. So one is that, and other disease in which the nitrates are contraindicated will be called hypertrophic obstructive cardiomyopathy. Can anybody tell me why?
Reducing the preload, it causes worsening the obstruction.
Exactly. Very good. How it will worsen the obstruction? Very good. Because
It reduces.
yes, hypertrophic obstructive cardiomyopathy is due to what? Is due to decreased left ventricular cavity size. And if you increase the preload, the left ventricular cavity size will further reduce, which will increase the intensity of the murmur and it will increase the symptoms. Okay. So do not use the drug which decrease the left ventricular cavity size. So one drug is actually called nitrates, and other drugs are diuretics. Do not use diuretics in these patients. Okay. And the last one is called when you actually combinedly use with those drugs which increase the cyclic GMP, like your sildenafil, phosphodiesterase 5 inhibitors. Phosphodiesterase 5 inhibitors. So do not use the nitrates in combination with the phosphodiesterase 5 inhibitors because both of them combinedly will increase cyclic GMP. And when you increase the cyclic GMP, what is going to happen? You're going to get what? Vasodilation and more hypertension will be seen.
More hypertension, severe hypertension.
Exactly. Now we discuss the anti-anginal therapy. Anti-anginal. Anti-anginal therapy is actually there. So anti-anginal therapy, what is the goal of anti-anginal therapy? The goal is to reduce the myocardial oxygen demand or to demand. And we can decrease the demand by decreasing the certain parameters by decreasing the preload. So we will use the drugs which decrease the preload or by decreasing the contractility. Okay. Or we decrease the afterload. So we will discuss the drugs which decrease the preload first. So the drug which decrease the preload, again, it will be nitrates. When I use the nitrates, it's going to reduce my preload. So after using the nitrates, what will happen to my parameters? So what is going to happen to my end diastolic volume? It's going to be decreased. Is it? And what is going to happen to your contractility? After using nitrates, my contractility what will happen to the contractility? Yep.
Reflex tachycardia.
Reflex tachycardia. So it is going to be increased because of reflex tachycardia. Okay. Going to be increased because of reflex tachycardia being there. Okay. So contractility increases because of reflex tachycardia. Okay. Now, what will happen to my heart rate? Obviously, it is going to increase because of the reflex one. All right, so you see contractility is increasing, heart rate is increasing. It means these parameters will increase oxygen demand. So it means nitrates alone is not a good drug for the angina treatment. It should be combined with other one, okay? So what will happen to my ejection time? When I give nitrates, my ejection time will increase or decrease?
Reduce.
Good, because heart is so quick, the heart rate is so high. It's going to be all right. So overall, what is going to happen to the myocardial oxygen demand? It will actually reduce, but not.
Increase.
It will reduce of the reduced preload being there. So it will reduce, but not that much reduce. But contractility is decreasing, heart rate is increasing, so it's a concern here. So to decrease that, we are using another drug that's called beta blocker. So beta blockers, when I use the beta blocker, what will happen to my end diastolic volume? It will increase or decrease?
You increase.
Very good.
Increase.
Because they will get a more time to fill. Okay. So my blood is going to be decreased, obviously, because it will decrease the cardiac output, contractility will decrease. Heart rate is obviously going to be decreased. Okay, what will happen to the ejection time?
Increase.
More time.
Increase. Delay.
Very good.
Increase.
And demand is going to be obviously decreased. But the problem with the beta blocker is that it might increase the end diastolic volume. It might increase the preload. So better is to combinedly use nitrates plus beta blocker. Plus beta blocker. Nitrates plus beta blockers are the best drug to treat your angina, okay? To treat the angina, nitrates, because they both will actually combinedly decrease your myocardial oxygen demand. So more oxygen demand, because one will decrease the preload, the other will decrease the contractility and the heart rate. So your oxygen demand is going to be decreased here, okay? So any patient in which the beta blockers are not suitable, like diabetic patients. So if any diabetic patient, if there's one patient who's diabetic and he gets a lot of the hypoglycemic episodes. So in that patient, beta blockers are contraindicated. So what drug will you use in place of the beta blocker?
Cardioselective.
Calcium channel blocker.
Selective. If I use cardioselective, that's the problem, is it? The problem, which drug is causing the problem? That cardioselective is causing the problems in the diabetics. Diabetics are getting glycemia, but they are not getting aware. So very good. I had one option that was called Verampapil. Very good. Calcium channel blockers. Okay. So try to anticipate in this way. Okay. All right. So that will be the anginal therapy for you guys. Now, if your angina is, I start the nitrates in the patient, I start the beta blocker, I start the calcium channel blocker, but still my patient is getting chest pain because of angina. It means angina is not treated with the calcium channel blocker, is not being treated with the beta blocker. So then what will be your next drug?
Aspirin.
Not aspirin.
Mm.
That is used for the refractory angina. That's called ranolazine. Ranolazine is actually there. Ranolazine that is being used to treat refractory angina because it has a completely different mechanism of action. So what does the ranolazine do? Ranolazine is going to block the sodium current. It's going to block the sodium channels. It blocks the sodium channels. So it blocks the late inward current of the sodium, blocks sodium channels. So when they block the sodium channels, what will happen? They will actually weakens your depolarization. Weakens depolarization. So when you weakens the depolarization, it means your contraction will be reduced, is it? So that will lead to weaker contraction. Weaker contractions. And when you get weaker contractions, what will happen? When you get weaker contraction, it means they will consume less oxygen, okay? Decrease oxygen consumption. So this is how the ranolazine works. Look at this, its mechanism is totally different from beta blocker and the nitrates. So that is why this drug is being used to treat refractory angina. Okay, simply they will weaken the contraction. Okay. All right, so that will be the use here. Now, what are the side effects of ranolazine? Because it's actually blocking the sodium channels. So it might block the sodium channels in the gut. So you might get the constipation here. You might get the dizziness, headaches, because they will slow down the left ventricular contraction. Okay. Now, other drug which we are going to discuss is called sacubitril. Now, sacubitril is what? Sacubitril is a drug which is going to inhibit neprilysin. It inhibits the neprilysin, so ANP, atyl natriuretic peptide, is actually converted into inactivated compound, inactivated by your neprilysin. Okay. So if I use a drug which inhibit the neprilysin, what will be the consequences of it? It will increase the ANP and decrease its inactivated compound. So drug is called sacubitril. Okay. So when I increase the ANP, what will be the consequences of it? It is going to do what? It's going to remove the water out of the body. So it is going to reduce extracellular volumes. Extracellular fluid will be decreased. And when you decrease that will be one effect. Another effect will be increase ANP will be causing vasodilation. You get nitriuresis. Okay. So, in what disease you want to decrease the fluid in the body? So that will be the clinical uses of this drug. Okay.
Heart failure.
This drug is being used to treat heart failure with reduced ejection fraction or systolic heart failure. Okay. And always it is combined with the ARBs. We combine this drug with the ARBs. Always ARBs plus sacubitril, they are combined. We never combine sacubitril with the ACE inhibitors. You know why? Why don't we use ACE inhibitors and the sacubitril together? Because both of them, you see, if I use ACE inhibitor, it will increase the bradykinin.
They would give the cough.
Bradykinin and the neprilysin inhibitors, sacubitril, it also increase the bradykinin. So both of them can increase the bradykinin together, and I will get what? Angioedema. And you know, angioedema is very severe, where I get the edema of the larynx and the facial areas. So that might lead to the respiratory difficulties in the patient. So that's the reason we use always ARBs plus sacubitril together. Do not use ACE inhibitor, because if you use it, you are going to get the angioedema and the more cough being there. Okay. So what are the side effects of sacubitril being there? Side effects. Yep.
Hypertension.
Very good. Hypertension, excellent, because
Hyperkalemia.
very good. Why? You know why it causes hyperkalemia?
Because it decrease the activity of aldosterone, increase the activity of aldosterone.
Very good. Very good. Excellent. Good job. Because aldosterone normally causes hypokalemia. It removes the potassium in the urine. So here you don't get the aldosterone effect, so you're going to get this. Very good. And other, it's going to cause the cough, obviously, because it increases the bradykinin. So you might get the cough and you might get the dizziness because of the hypotension. Okay. So that was all about sacubitril. Now we're going to discuss the lipid lowering agents. So lipid lowering agents means they will decrease the lipids. So in the blood, we have the two types of lipids being there. Lipid lowering agents are there. We have the two types of lipids. One is called the cholesterol and it's called triglyceride. Lipid lowering drugs. So first we will discuss the drugs called cholesterol lowering drugs. So drugs which are cholesterol lowering. So you can decrease the blood cholesterol. How can you decrease the blood cholesterol? You can decrease the blood cholesterol by three mechanisms. So one mechanism will be what? When you decrease the dietary reabsorption of cholesterol, act on the gut, dietary reabsorption. So there's a one drug which is going to decrease the dietary reabsorption of cholesterol by blocking the interstitial brush border. And what's the name of that drug? That name of that drug was called ezetimibe. Okay, ezetimibe. So ezetimibe is going to do what? It is going to decrease the cholesterol absorption from the gut at the small intestine. It blocks cholesterol reabsorption. Okay. So simply blocks cholesterol reabsorption at the gut, and you will get what? Decreased blood cholesterol. Okay. So when you use cholesterol ezetimibe, it's going to decrease it. Now, what will be the side effect of ezetimibe? If my cholesterol remain in the gut, what side effect?
Vitamin.
Yep.
Steatorrhea.
Very good. You might get what? Diarrhea, because osmotic cholesterol is osmotic agent, you get diarrhea. And every cholesterol lowering drug, every lipid lowering drug is very hepatotoxic. So you might get the raised LFTs. Liver function test will be raised. Okay. So that will be your lipid lowering drug one. So one mechanism is to act at the gut. Now, what will be the other mechanism to actually decrease the blood cholesterol? It will be other mechanism is to decrease endogenous production of cholesterol. Is it? Whatever body is producing, I should target that. Okay, endogenous cholesterol. And there's a medication which is most important medication to know that will decrease endogenous cholesterol. So do you guys know that endogenous cholesterol is produced in what tissue? What tissue in the body produce endogenous cholesterol?
Liver.
Liver.
Excellent. Liver produces the cholesterol being there. So liver is going to produce the cholesterol. So I will decrease the cholesterol synthesis in the liver by inhibiting the rate limiting. So mevalonic acid, I just discussed is mevalonic acid or mevalonate is converted into cholesterol by the enzyme that is called your HMG-CoA reductase enzyme. So this is a rate limiting enzyme in the cholesterol biosynthesis. So, liver cholesterol is produced by this enzyme HMG-CoA reductase. Now, liver cholesterol is actually there, so I can inhibit the liver cholesterol synthesis by actually acting on this enzyme. So this will be your statin. So statin are the drugs which will inhibit this enzyme, statins. So what drugs are going to inhibit this enzyme? Statins, like your atorvastatins, rosuvastatins, simvastatins. These are statins which will block this. So when I block this, my cholesterol synthesis is going to be reduced in the liver. Okay, so you guys know that liver is very liver is very sensitive to the cholesterol changes. Liver have to maintain the reserve pool of the cholesterol. So normal reserve pool of the cholesterol in the liver is actually 400 milligrams. Liver have to keep the 400 milligrams within itself. Without 400 milligrams, liver cannot survive. Liver cannot survive. So this is the normal value liver have to keep in it. So when I start the HMG CoA reductase inhibitor, what will happen to the liver reserve pool? The liver reserve pool is going to be decreased to 200 milligrams. Is it? 200 milligrams. So liver will do everything to actually restore its reserve pool. So from 200, it have to go back to the 400. So what will liver do? What liver is going to do? Liver is going to import the cholesterol from the blood. From the blood. You guys must be thinking, I use the statin to reduce the blood cholesterol. But how the statin reduces the blood cholesterol? It reduces the blood cholesterol indirectly, not directly. First, it will act on the liver and it will actually reduce the store pool of the liver from 400 to 200. Now, liver become very conscious. Liver become conscious and liver become exaggerated. So, what will the liver do? So, suppose this is my blood. This is my blood. This is my blood. So, at the start of the statin drug, my blood cholesterol was 350 milligrams. 350 milligrams. This was the day one of the statin. At the day one of the statin, this is day one of the statin. 350 milligrams. Now, after 6 months of I'm just giving you the example. This is not reality. Okay. After 6 months of the use of the statin, my blood cholesterol go from 350 to your 150. It goes to 150. So where does this 200 cholesterol go? This 200 cholesterol from blood, it goes into the liver. Liver actually import the cholesterol from the blood. And if liver is importing the cholesterol, so liver must have to produce its efforts. Now my question is that how will the liver remove the cholesterol from blood? Can anybody tell me the answer?
LDL receptor
Increase LDL receptor.
after regulation.
It's going to increase the number of LDL receptor on its surface. LDL receptor.
Yeah.
This will be the effect. Very important to know. So what is the effect of the The statin use will increase the number of LDL receptor in the cholesterol. So LDL receptor on the surface of the liver, so LDL will go into the cell. Okay, LDL will go into the cell. So you get what LDL is going inside. So your blood cholesterol will be reduced. Why? Because statins will increase the number of LDL receptor on surface. Okay, so this is the effect of the LDL, your statin. Very important to know. Did you guys understand this effect? Get it?
Yes.
Okay. Now, after using the statin, your LDL level will actually decrease so much. It decreases your LDL so much. It's very effective drug in reducing the LDL, and it's also increased the HDL, which is a good cholesterol being there, and it decreases the triglycerides. Okay, side effects of the statin. What are the side effects of the statin?
Myopathy.
Mm-hmm. Side effects of statin, they are actually going to be, statins
Hepatotoxic.
Hepatotoxic.
cause the rhabdomyolysis, and this
Myo.
myopathy
Myopathies.
pronounced when we combine statin with the fibrates. Okay, when you combine them with the
Yes.
myopathy is going to be increased. Okay, now other side effect will be they might cause hepatotoxicity.
Yes.
So they will raise your LFTs being there. So T with the statin will be increased when you combine statin with the fibrates plus niacin. Okay, so that's all about your statin group, and statins are the very, they decrease the mortality in the coronary artery disease patient. Okay, what other medications are there? Yep, which we can use to decrease the. So I discussed the two ways. One way is to reduce dietary cholesterol reabsorption, another way is to reduce the endogenous production of cholesterol. And what is the third way to decrease the blood cholesterol? Third way. The third way to decrease the blood cholesterol is to increase
Bile.
the use of cholesterol in the body, convert the cholesterol into their products, into the non-toxic products. So how I can actually convert? So I have to convert cholesterol in the liver. So this reaction is also happening in the liver. So I have to convert cholesterol into the bile acids. Okay, so what is my task now? My task is to convert cholesterol into bile acids. How I'm going to convert this into the bile acids, that's we are going to do now. Okay, so what happens, suppose you see this is my liver. This is my liver. I'm drawing it bigger because of some purpose. This is my liver, and this is my gut. This is my gut. So what happens, normally the bile acids come into the guts. Bile acids come into the gut normally, and bile acids are important for the fat absorption. They are involved in the absorption of the fats. So after completing the fat absorption, they come to the terminal ileum. So at the terminal ileum, we do have the bile acid receptors being there. Okay, at the terminal ileum, we do have the bile acid receptors being there, and these bile acid receptors will do what? It will lead to the enterohepatic recirculation of the bile acids. So after the complete use, the bile acids will be returned back to your liver. Okay, and this is called enterohepatic recirculation. Enterohepatic recirculation. So in this way, the liver maintains the normal pool of the bile acids. Suppose the normal pool of the bile acids in the liver is actually your 20 milligrams. So without this 20 milligrams, the liver cannot survive. Okay. So this is normal pool and it's being maintained by enterohepatic recirculation. Now I can use the drugs which can reduce this 20 milligrams to your 5 milligrams. So the only way to convert the bile acid from 20 milligrams to 5 milligrams is to inhibit this enterohepatic recirculation. So if I enterohepatic recirculation, the bile acids pool will decrease from 20 to 5 milligrams. So what are the drugs? These drugs will be the drugs which blocks the bile acid reabsorption, and these drugs are called bile acid resins. Bile acid resins. Resins. Okay, so these drugs are called bile acid resins, so they will actually disrupt the intrahepatic recirculation. So what are the names of these drugs? These drugs include cholestyramine, cholestyramine. These are the drugs which actually bind with the bile acids and will disrupt the bile acid reabsorption. Or in a simple word, they will keep the bile acids in the gut and will lead to increased excretion of bile in the stool. Okay, so the question is that will actually reduce their effect is what? They will reduce the liver reserve pool of bile acids from 5 from 20 to 5. So what will the liver do? Liver will actually convert your cholesterol into bile acids. And when you convert the cholesterol into bile acids, the bile acid reserve pool is maintained, but liver again become in trouble because liver's reserve pool of the cholesterol will go down from 400, which is normal, to your 300 this time. To your 300 this time. So then what will the liver do? Liver is going to import the cholesterol. So whenever the liver pool decreases, liver is going to import the cholesterol. So how liver is going to import the cholesterol? Liver is going to call the blood. I need cholesterol. And in the blood, there's a lot of the cholesterol being there. In the blood, I have already 250 cholesterol being there. So liver is going to do what? Liver is going to remove 100 cholesterol by increasing the LDL receptor. So can I say like this, the effect of cholestyramine and the cholesterol is what they indirectly increase the number of LDL receptors on the surface of the liver. So LDL will go into the liver. So this
So
is
upregulation of the LDL receptors.
exactly. In a nutshell, I will say at the end, they increase the upregulation of. So whenever your cholesterol level goes down in the liver, liver become crazy. Liver become crazy, keep synthesizing the LDL receptors. Okay. So that's how I actually reduce the cholesterol in the body. So after using this drug, after using this cholestyramine, the cholesterol drug, my LDL level will decrease. What will happen to my triglyceride levels? That's important to know here.
Not much.
Increased.
Very good. It slightly increases because you are disturbing the triglyceride flow. If you disturb the triglyceride flow, it's going to be increased. Okay. So this is how we increase the triglyceride levels. All right. So that's all about your. So this is the only very important to know. Bile acid lowering drugs are the only drugs which increase the triglyceride level. Rest of all lipid lowering drugs decreases your triglycerides. Okay, so this is how we decrease the cholesterol level. Now have to decrease the. Now we are here to decrease the triglycerides. Okay, all right. Now the drugs which decrease the triglycerides. So how can I decrease the triglycerides again? So I have to decrease the triglycerides by decreasing the conversion of your, is it? I have to decrease the conversion of your free fatty acids into the triglycerides. So first drug is called fibrates. We're going to discuss the fibrates here. That's an important group for there. So fibrates are there, and in fibrates, what drugs are coming? Phenofibrates and the gemfibrozole. Fibrates. So your fibrates are acting at the nucleus level. So what does the fibrates do? Fibrates are going to activate the transcription factor that is called peroxisomal proliferating activating receptor.
Alpha.
So this is a transcription factor, and this transcription factor is going to do what? It is going to increase the gene expression of your enzyme called lipoprotein lipase, which is present on the surface of endothelial cells. Now, this lipoprotein lipase will do what? It will convert the blood triglycerides into your free fatty acids. And what will happen? These free fatty acids will be going into the adipose cell. Okay, it's very simple mechanism for the fibrates is there. So when you increase lipoprotein lipase enzyme, it's going to convert blood triglyceride into the free fatty acids. So you get what? Adipose cells. They will go to the adipose cells being there. Okay, so this is how your fibrates are working. Okay, so fibrates will convert what? Convert blood triglyceride into free fatty acids, which will go into the adipose cells. In this way, you decrease the blood triglyceride level. Okay. Now, fibrates also increase the enzymes, which will increase your LDL synthesis, HDL, sorry. So it increases HDL synthesis as well. All right, so this is how your fibrates work. Now, what will be the side effects of the fibrates? Side effects. Yep.
Myositis.
Very leads to rhabdomyopathy. Myopathy will be there. Very good. So you get myopathy, which is increased when you use with the statins. And fibrates, very important side effect, it can increase the risk of cholesterol gallstones. Cholesterol gallstones. And you guys must be thinking why. So why fibrates increase the risk of cholesterol gallstones? Because fibrates will decrease the synthesis of the bile salts. And when you decrease the synthesis of bile salts, what will happen? The cholesterol will precipitate as a cholesterol gallstone. You guys know that normally cholesterol is converted into bile acids and the bile salts by one of the enzyme. What's the name of that enzyme which convert cholesterol into the bile?
7-alpha hydroxylase.
7-hydroxylase. Okay. So cholesterol is converted into your bile acids. 7-alpha hydroxylase. So your fibrates will inhibit this 7-alpha hydroxylase. As a result, you get more cholesterol and less bile acids, which will precipitate as a gallstones. Okay. All right. So that will be your fibrates for you. Now, after fibrates, other lipid lowering agent, which is going to decrease the triglycerides, will be called niacin. And what does the niacin do? So niacin is going to do what? Niacin.
Increases HDL.
Niacin do what? Niacin is going to decrease your triglycerides. Question is that how does the niacin decrease triglycerides? So suppose this is your adipose cell. Within the adipose cells is the triglycerides being there. So triglycerides are there within the adipose cells. So this triglycerides in the adipose cells, it's actually normally converted into free fatty acids by one of the lipase. What's the name of that lipase? That will be called hormone
Sensitive.
hormone sensitive lipoprotein lipases. Okay, so this adipose cells do what? Adipose cells also maintain the reserve of the triglycerides. So normal reserve of triglycerides in the adipose cells is how much? It's actually, I'm just giving you the example, it's at 100 milligrams. So triglycerides will be maintained within the adipose cells. That will be 100 milligrams. So adipose cells will do everything to maintain this reserve pool. Now, if I increase the activity of this hormone sensitive lipase, what will happen? It will actually decrease the triglyceride level in the adipose cells from 100 to your 50 milligrams. 50 milligrams. So what will that adipose cells do? Adipose cells will call whom? It's going to call to which organ to for the triglycerides? It's going to call to the liver.
Liver.
That liver is very sincere with the adipose cells, is very loyal to the adipose cells. Liver will do everything for the adipose cells. So what will the liver do? Liver is going to give triglycerides to the adipose cells. So first liver will do what? First liver will send the triglyceride to the blood. Is it in the form of the VLDL? Is it? In the form of the VLDL. In the form of VLDL, liver is going to send the triglyceride to the adipose cell. Now this VLDL will be going into the triglyceride cells. Is it? So VLDL is going to the adipose cells. So first liver have to throw the VLDL into the blood. So if liver throws VLDL into the blood, it means the blood triglycerides will increase first. Is it? So what I have to do, I will do what? I will actually maintain this pool. I have to maintain this 100 pool so that the adipose cells should never call the liver for triglycerides. Because if the adipose cells call the liver for triglyceride, liver first release triglyceride in the blood, which might increase my blood triglycerides. So what does the niacin do? Niacin will inhibit this hormone sensitive lipase. So when niacin inhibit the hormone sensitive lipase, what will happen? Adipose cells pool is maintained every day. every day adipose cells pool is maintained, so it will never call the liver to release VLDL. It will never call the liver to release VLDL. So what will happen if the it will never call the liver, so liver will not release VLDL, okay? And if the liver doesn't release the VLDL, I will have the decreased triglycerides. Okay, so this is how the niacin work. Niacin inhibit the degradation of triglyceride within the adipose cells. So adipose cells triglyceride never go down. As a result, your liver will not release more VLDL. So you get what? Less triglyceride in the blood. So it indirectly decreases your blood triglyceride level. So this is how your niacin is actually working. Okay, did you guys understand mechanism here? Very simple.
Yeah. Yeah.
Okay, now what are the side effects of the niacin?
Flushing.
Flushing.
Flushing, excellent. You might get the flushing. Very good. You get the flushing.
Hyperuricemia.
No, this flushing is due to niacin.
It is due to release of prostaglandins
Prostaglandin.
and is treated by aspirin.
It's treated with the NSAIDs because flushing can be caused by flushing can be caused by other drugs as well, which are due to the histamine release like vancomycin, IV contrast dye, opioids. So that's being treated with the antihistamine, but here the flushing cause is by prostaglandin. So better is to treat it with the NSAID, or it will be resolved with the long-term use, okay, because of the and niacin can also cause hyperglycemia and hyperuricemia. So this drug should not be used in
diabetics and gout.
Or the gout patient. Very good. Now, last drug, which is lipid-lowering drug, that is called the monoclonal antibody, which inhibit the enzyme that is called your I don't know why I cannot write it. PCSK9 inhibitor. So what does a PCSK9 do normally? What does a PCSK9 do normally? PCSK9 normally do what? It
Degrade the LDL receptors.
Helps keep the LDL receptor alive. Oh, no, degrades it. Sorry, it degrades it.
You're here?
The LDL receptors.
You're here today?
Oh yeah, I'm here. I'm here.
Why are you not speaking? You should talk because your colleagues need your help. Okay?
I slept for a while too in the class.
At least you get a
I
time.
slept and woke up in dream.
You get a time to sleep, I cannot sleep.
I know, right?
Okay.
Take your work. Thank you.
No problem. Okay. So LDL receptors are going to be, so you see LDL receptors are degraded by your PCSK9. Okay. Degradation. So no need to remember the full form protein convertase, stilbeer kinase. Just remember PCSK9. Okay. So if I inhibit this enzyme, what will happen? I will increase the number of LDL receptors on the surface of the liver. Okay. So what are the monoclonal antibodies which can inhibit this one? That's called your evolizumab. Evolizumab or elizumab is there, which is going to inhibit the PCSK9. Okay, so this drug is also very effective in lowering the LDL, and it's being nowadays used. Okay, it's being used nowadays, so it's going to decrease the LDL level in the blood. Decrease. Okay, so these are the drugs, and the mechanism is there. All right, so what are the side effects of these drugs? Because of side effect profile, these drugs are not preferred in the older adults. And this drug has a neurocognitive, it's going to decrease your neurocognition because it can cross the blood-brain barrier, and it might lead to what? Neurocognitive effects will be there, and it might lead to delirium, myalgias will be there. Okay, dementia can be seen. So because of these side effects, this drug is not preferred. Statins are always preferred, but nowadays we can use these drugs in the younger patients because benefits are high compared to the risk. Okay. All right. Now last is called fish oil and omega-3 fatty acids, which are actually in your diet. They are not the drugs; they are within your diet. So omega-3 fatty acids are the they are going to do what? They're going to decrease your triglycerides. Okay. So they are decreased how does they decrease the triglyceride? Because they will decrease the delivery of free fatty acids to the liver. So liver will have the decreased free fatty acids available to produce triglycerides. Okay, and their side effect will be fish-like taste and the nausea will be there. All right, so this was all about lipid-lowering drugs. Now we have the antiarrhythmics. So I'm planning to do this antiarrhythmics tomorrow in the half hour. I don't want to rush through them because it's already being late. So we're going to do these antiarrhythmics tomorrow because I don't want to rush through them. And in the half an hour, I can actually do this. I think you guys are feeling tired. So
Yes.
is it? Okay. So better
Can you also tell pathology afterwards?
pathology. I think you guys are good in the pathology.
But you tell very well, like
Maybe
it sticks.
the tachycardias,
What do you suggest, Mister?
the long T Torsades, long T Brugada, and Wolf Parkinson.
But what are you guys? You are good in the
Those ones.
don't need forgot. Okay. Okay. So what we can do?
And then the vasculitides.
Vascularities are not here. Vascularities are covered in the MSK. I cannot cover here.
Oh yeah.
I cannot cover the vascularities here. Okay. They are in the MSK.
Oh, they have it on the prostate.
Uh-huh. Mm-hmm. So just you guys wait for 1 minute. Just get one for minute. I'm here. Okay. Just wait for.
Thank you so much.
Wait here. I'm here. I have to do something.
Sure is weird, man. People just take them left.
Oh, here you go. Here you go. You left them here. Here, it's on the table.
Oh, they are on the table?
You already poured some.
So, help me maintain my cool. Because I
Yeah.
swear every once in a while, I say.
Oh, you said you were gonna give me one beer. You took one, but did not give me one.
Okay. You got one. You had yours.
Okay.
You didn't get yours?
I didn't. I'll take it.
Okay. Okay. So I think we can continue tomorrow.
Thank you, sir.
I see the wonderful.
Oh, that's yours.
I see the wonderful.
Who's yours?
I'll go take one.
I'll go get it for you.
Please give the comments in the group.
One of us has got to go get it.
I'll go. Don't worry.
No, I'll get you.
I got it. I'll take the beer.
Sir,
Yes.
humble you.
Is there a neurology?
Oh, an athlete.
Okay.
Yes. So I see the good comments in the chat box. So please give a good comments in the group so the management have the look at my work. Okay. I'm just kidding. It's up to you guys. Okay. I'm just kidding.
No, I just wanted to
Thank you
ask.
so much. Thank you so much. I will.
Boot camp?
So what were you asking? Somebody was asking the question. What did you ask?
Is there a boot camp for CNS also?
Yeah, there will be the boot camps for everything.
Oh, okay. Okay.
Every boot camp will be there. Don't worry.
Yeah. Will it be
Whom
informed?
can we contact? Yeah, whom can we contact?
Sorry, what did you say?
Whom should we contact? She's asking.
For what?
For boot camps.
For the next sessions and how to subscribe.
Oh,
Sir,
yeah.
I think the people who
Check
just
out your
joined
sponsor
who are not part of
hospital.
the group are asking. So
Uh-huh.
maybe they need to join and then they will be updated about it whenever it happens.
So you can you can contact with the Dr. A is there, who's actually our manager, and you can contact. Do you have a contact number of that guy?
No.
You guys
Sir,
don't?
I think he put up the link on the cardiology bootcamp group, so
Yeah.
they should be able to contact him through that.
Yeah, I think you can contact with that guy, and he's a manager, he's a leader, he's leading the group. Okay, I think this is the number being there. You can contact to him.
716.
So this guy was about to come for the your intro, but I don't know. I saw his message now. I was in the class. Yeah, there's a number being there. You can contact to him, and any new students who wants to subscribe, you guys can contact with this person, and he's the manager. Okay. So tomorrow we start the endocrine, and we do the anti-arrhythmics first, and then I will start the endocrine with you. Okay.
Hello, sir. I have a question.
Yeah. Hello, Sarah. How are you?
I'm good, sir. Thank you. So, sir, have you decided anything about basics? We are badly waiting for your response. Like we were waiting that you get like free with the application and everything, so we can hear from you.
Yeah.
Yes, sir. I second Sarah. We've been waiting for the crash course for basic general principles.
Yeah, we can start, but I'm a little bit busy nowadays. So let's see. I mean, they asked me to start. So how many students are there total?
Sir, I think like
Well,
there were,
Much
it's
everybody
all of the
wants
Bay batch.
the
We never
general
did. We never did
principles.
basics.
yeah, we created pool in two different groups. So in one there were 27 students who were willing to do, and in the other there were almost 15, 16 students like who wanted to do.
Yeah, I think pretty much everybody wants to do the general principles.
So okay, we will see how many students are there.
Oh my God, I'm too sick.
Then we can start. We can start. Let's
So to save you from time, they can just make you do basics with September, and we can just join them.
Let's see how things go for you, Jones. We cannot decide. It's a management one because I cannot say anything. I cannot make.
Okay. Okay, that's fine. No problem.
Yeah, I cannot make any commitments. Okay. I cannot make any commitments. So let's see how things go. We will inform you guys. Don't worry. Okay.
So sir, do you have time for our basics class? Like will you be able to manage it or no? It's difficult for you.
I will see, because if I have the time, then I will take the batch. Otherwise, I will not take. Because if I take it, I have to give the proper time. Is it?
Yeah.
Once the commitment is met, that's the reason I am not actually making the commitment. Okay. So I have to look at my schedule, how things go for me. Because once you make a commitment, you should give a proper time to that batch. Because
Yes.
it takes a time. You prepare the lecture for the students, they are coming, they're investing their time, they're investing their money, so better is to give them the good results and the good lecture, is it? So that's what
Yes.
I think. So let's see. If I cannot make a commitment, so I have to look. That's the reason I'm actually looking at my schedule. Okay.
Okay. Thank you, sir. Thank you. Thank you
Thank
so
you.
much.
Thank you.
Bye bye, take care.
Thank you so much.
Bye.